being a co-chair of this conference, Diabetes and Obesity Con 2026 Special Edition about the Obesity Masterclass 360. So today we will be discussing around 8-9 topics online, and we have wonderful faculties over here. And this conference is all about obesity, covering all the topics related to the obesity and associated problems suffering from obesity. So to briefly describe and how we are going to proceed about this conference, Dr. Rima Madam will take over to guide us about the further plan and proceedings. Thank you, Rima ma'am.
A very warm good evening to one and all who's here and to all the delegates who have registered to the Noble Hospitals initiative of the third edition of DNO Con, and that's a special edition that is rotating around everything around the obesity. So I would like to first take up on the topic which will actually lead you towards as to why Noble Hospital thinks that this conference should be taken on and such conferences should be held. So to start with, the topic that I'm going to speak is adipose tissues pathophysiology from fat storage to the metabolic dysfunction. What I mean to say with this is that why once upon a time, the fat storage or the adipose tissue or the fat cells were just considered to be uh, just a storage organ, and now they are called to be an endocrine organ, and they are now supposed to be called as the hub of all diseases that are there in the future pipeline. And now that obesity is called as the mother of all diseases, it's important to discuss that adipose tissue is now just not a storage organ, it's an endocrine organ. It's because it talks to the whole body, it communicates with the rest of the body through other hormones and other signals. So, what is adipose tissue? Actually, adipose tissue in the body are two types. One is a white adipose tissue, and second is a brown adipose tissue. The white adipose tissue is actually an energy storage depot that stores energy as triglycerides, and this is located under the skin and around the organs. The brown adipose tissues, on the other hand, actually burns energy to make the heat. It is rich in mitochondria, and therefore the color of this adipose tissue is brown in color, and so it's called as the brown adipose tissue. Now, something we have in the body that is called as healthy fat, and the other thing is an unhealthy fat. The healthy fat is a good adipose tissue, and the main function of good adipose tissue is that it's a storage organ that takes up all the excess calories after meal when we eat food. Second, it releases energy and gives body the energy or the fuel that is there when we are actually in a fasting state. The third and the most important function of adipose tissue is that it makes certain hormones like leptin, adiponectin, and these are the hormones that actually signals the brain and the liver that yes, we have enough energy or we don't have enough energy. And to secrete the hormones and to maintain a hemostatic mechanism in the body about having storage or about correlating with the storage function of the body and with the release mechanism, this is one of the prime function of the adipose tissue. And last but not the least, adipose tissue works as a cushion and an insulator that protects all our internal organs. So if I want to say in a layman language, just think of adipose tissue that it is like a safe and expandable warehouse. Now, what goes wrong that a good adipose tissue, which I discussed in my previous slide, becomes a bad adipose tissue. So what actually happens is that when we eat more than what we burn, fat cells actually go into energy surplus. And this energy surplus results in the body in two types. One is the fat cells hyperplasia, and second is the fat cells hypertrophy. If there is hyperplasia, that means there are more number of fat cells that are formed as a result of energy surplus, and this is called as the healthy expansion of the fat cells. On the other side, when it is not in hyperplasia, it's hypertrophy. This means that the number of cells are not multiplied, however, they have become bigger and fatter, and this is actually where the trouble starts coming in the body in the form of the good adipose tissue becoming a bad adipose tissue or the bad fat cells. What actually happens in this hypertrophied cells is the big cells actually do not get enough blood supply and so they become hypoxic. The immune cells, specifically the macrophages, move inside these hypertrophied cells and they cause inflammation. Third, the tissues become stiff, which has hypertrophied cells, and they're not able to expand properly, eventually leading to the fibrosis of these tissues where these hypertrophied fat cells are there. And last and the most important is that when the fat cells are hypertrophied, in contrast to the normal adiponectin and leptin secretion, there is more secretion of inflammatory markers like TNF alpha, IL-6, and many other which are not put into these slides. And this leads to actually the dysregulated secretion of the hormones in and out of the tissues, leading to the bad adipose tissues disease formation. So again, if I talk in a layman language, it is that warehouse which was actually safe and expandable. This starts leaking and sending alarming signals to the body. And this leaking of the adipose tissue actually causes a spillover effect wherein the fat cells do not remain adherent to the fat cells only, and they start spilling over the organs like liver, muscle, pancreas, heart, and this is called as the ectopic fat deposition. And it is this ectopic fat deposition actually that leads to insulin resistance in this organ and leading to a cascade of mechanism that eventually cause the syndrome that is called as the metabolic syndrome and leading to the clinical outcomes that we physicians come across like diabetes mellitus, wherein the liver and muscle stops responding to the insulin, like fatty liver disease where the liver gets overloaded with fat, cardiovascular disease due to the inflammation that is combined with dyslipidemia as a result of excess fat accumulation inside the body, and last but not the least, chronic low-grade inflammation that just does not remain the adipose tissue as a bad fat cells leading to the cardio kidney metabolic disease, but also leads to any other disease in the body, including the cancer and all other inflammatory diseases, thereby reducing the immunity of the body and making a person or leading to the cascade of events that ends up from one to another. And so what is more important is where the fat cells is. What is the good fat cells and where is the bad fat cells? So it is the subcutaneous fat which is under the skin, which is actually a better at the stage storage, and this is called as the good fat. But the fat which is there around the organs, which is called as the visceral fat, this is something which is more inflammatory, and this is something which links the body towards going towards the more metabolic diseases. So this is how a good fat cells become a bad fat cell, a good adipose tissue become a bad adipose tissue, and eventually leads the body to the metabolic diseases. But the hopeful part is that adipose tissues or the fat cells are actually like a plastic, they are malleable. So when we work upon these fat cells, the results are very good. Like when we work upon weight loss or when we aim about having the hypertrophied cells going towards the normotrophied cells, then it reduces inflammation and improves the hormone profile. Second, exercise is a very important part to control the good fat going towards the bad fat. Now, when we talk about exercise, we think that exercise is only for weight loss. However, with regards to talking about adipose tissue, if we exercise, it improves the adipose tissue function irrespective of causing the weight loss. So one should not exercise just for weight loss or targeting weight loss. Doing exercise will improve your adipose tissue function and eventually will lead a person towards not going towards the metabolic disease spectrum. And the most important part is the therapeutic intervention on the fat cells in the form of the weight loss drugs like GLPs and GIPs, or in the form of interventions like balloon insertion, or in the form of bariatric intervention. And all of these together in the form of therapeutic intervention targets the target inflammation, and that is the insulin sensitivity or the fat cell distribution. So, what we have to actually aim when we talk about obesity is not just weight loss, is not just exercise, or not just therapeutic interventions. The goal is actually not no fat. The goal is the healthy fat function. And so, for having attaining such aims, we have designed this conference. And the take home for this conference, you will see that with the beginning of this session, with my talk of adipose tissues from the fat cell storage to an endocrine organ leading to a metabolic disease, you will find eventually the speakers, one after another, will talk something or the end that will rotate 360 degrees around the fat, whether it's the fat overload, whether it is the inflammation and spillover, which means the pathophysiology, whether it is the systemic dysfunction, insulin resistant treatment targets, bariatric surgeries, decision making, and everything and anything that rotates around the obesity. So, what we aim by this conference that is held on by Noble Hospital in 2026 is that if we understand adipose tissue, we actually understand the root of much metabolic diseases. And I hope that all the delegates who are here from today till tomorrow will actually have a different perspective towards looking at obesity or metabolic disease as a spectrum of disease which leads to other diseases, and we get over with a different learning. Thank you very much for this opportunity for opening the session from Noble Hospital. I hand over my session. Thank you.
Thank you so much, ma'am. That was a very a gist information on how what this conference would be, and it was a very nice and a simple thing. Ki what obesity is just not about the external looks, but it's actually a disease which can affect each and every part of the body. Just one question, madam. Can what do you think? Can a person with a normal BMI still have adipose tissue dysfunction?
Yes, very good question, Dr. Kritika. So this is called as, specifically if we talk about the Asian population, we in India are belonging to the southeast part of the Asia. So most of the Asians and Asian Indians have normal BMI, but they do not have a normal adipose tissue because the adipose tissues, they are more distributed over the central part, and that is the visceral obesity. So this is something which is called as obesity with a normal BMI, which is the central obesity. We Indians are therefore called as, or rather the Asians are called as, the lean fat Indians. However, the BMI is not just the criteria for labeling a person living with obesity. There are many other criteria. So we have to do a comprehensive evaluation of a patient in terms of labeling a person and an obese person. BMI is one of them. Waist hip circumference, just waist ratio, the body percentage mass, the body fat percentage that we calculate on the basis of the BCI are other criteria by which obesity is being labeled on.
Okay, that's how we get to know that having just a normal BMI is just not enough. So moving on to our next session, we call upon Dr. Manoj Durerat sir, who will be talking about his talk on golden window period for referral for heart transplantation. So welcome, sir. Over to you.
Thank you. Are my slides visible? Can you see my slides?
Yes, sir, we can see your slides.
Okay. Thank you, Dr. Rima, and the organizing team for having me over. It's very interesting that we are looking at the root cause of all the problems which we are having with the end organ damage. And I think the speakers after me also will be talking about the downstream effect of what mismanagement of adipose tissue, especially the bad fats, have on various end organs. Like we see coronary artery disease, ischemic heart disease, which leads to end-stage heart failure, and is a primary cause of reason why we're doing heart transplants. So I'll be discussing over the next maybe 10-15 minutes about what the spectrum or the clinical picture of heart failure patients we see, and what is the actual optimal timing for a heart transplant in our country. You will be actually shocked to know that most of the heart failure, end stage heart disease, which we see or referred for heart transplant, have passed actual golden window when they should be actually referred. So there are 4 stages of heart failure. So I'll just go through that quickly as a revision. Stage A is the patients at risk for heart failure. That means they don't have any symptoms, but these are patients who come into the category which we can manage, treat, like hypertension, cardiovascular disease. The other thing which we need, and Secretary of the Heart Failure Society, I've been having a couple of webinars concentrating on genetics and genetic mutations, and what we can do at that level in predicting how these cardiomyopathies can either be treated early or not allowed to progress into end-stage heart failure. Stage B is when they get into pre-heart failure. That means they still don't have signs and symptoms, but evidence of structural heart disease. So they could be having, increased filling pressures in the echo, coronary artery disease, which may be starting to arise. And sometimes we see obviously raised natriuretic peptide levels, and they might have elevated cardiac troponin level. Stage C is the common group of patients whom we normally put on guideline-directed medical therapy, which I think most of us are aware of, 4 pillars, 5 pillars now. And these are the patients who actually should be listed or at least counseled that they are potential candidates for a heart transplant. And this is where we miss the boat. And then a patient gets into advanced heart failure, which actually maybe really, really advanced heart failure candidates who have LV dysfunction, they have an LV aneurysm, clots, they end up with in the ICU. When you do the echo, you find that they have severe LV dysfunction, 50 to 20% EF. Actually, it should be the other way around. Or you have patients with end-stage renal disease, and they come with anuria or oliguria, and find that it's basically a cardiorenal syndrome. For us, the clinical indicators for heart transplant are thus that one of these criteria should be met or present despite optimal GDMT, that is severe persistent symptoms of heart failure, NYHA3, that's advanced ambulant heart failure as we call it, or NYHA4, severe cardiac dysfunction defined by more than one of these criteria, LVEF less than or equal to 30%, isolated RV failure, something which we tend to miss. It's picked up by a TAPC, what we call in the echo. I think most of the echo reports which are reporting left ventricular failure should also report the right ventricle in the form of TAPC, that is tricuspid annular planar systolic excursion. And if it is more than 17 mm, it's a normal right ventricle. But if it's less than 14, then we should consider it as a right ventricular failure. There are also non-operable severe valve abnormalities, like you have patients with severe MR, severe AR, bovine hearts, and we condemn them. I think these patients should be considered for a transplant if the pulmonary artery pressures are normal. Then there are non-operable severe congenital heart disease patients. Sometimes they go through multiple surgeries like BD Glens and Fontans, Norwoods, but these patients should have been considered for a heart transplant in the initial go. The other areas which we need to look at is once the patient gets admitted for that index heart failure, there's a downward cascade of repeated heart failure admissions, and each time the patient comes in, we call them the frequent flyers. The mortality and the morbidity rates increases, and if they are not caught in time, sometimes obviously the admission results in mortality. Now, hospitalizations or unplanned visits in the last 12 months for episodes of heart failure, like a patient who already is on guideline-directed medical therapy, they come to the OPD with escalations of diuretics, oral or IV. These patients, your antennas should go up that the patient is in worsening heart failure and may crash at any time. Sometimes this patient come with oliguria. They might require admission with dobutamine or mildenone and IV Lasix. So these are the patients we should consider. Some patients, have malignant arrhythmias, either ventricular or right ventricular. I mean, RV or LV arrhythmias, and these patients also come in the high risk group. There's something called VO2 max, which is a bicycle ergometer with a cardiopulmonary exercise testing, which we do regularly for our heart failure patients. And if it is less than 12 to 14 ml per kilogram per minute, we list them for a heart transplant. Now, the VO2 max is normally done in my cardiac recovery room. We have, because these are patients with LVs of 15-20%, and we should be ready for any crashes. And this is the machine with the bicycle ergometer. You would have seen all the Olympic athletes and other people using this machine. We use this regularly for cardiopulmonary exercise testing and having objective evidence that this patient is end-stage heart failure. This is very important to note that this category of patients like INTERMAX, this is the Interagency Registry for Mechanically Assisted Circulatory Support. We normally use this as a criteria to clinically categorize our patients who are very sick and who are stable but sick. The Intermax 1 is a patient with critical cardiogenic shock. The Intermax 2 is progressive decline. That means the patient is dependent on inotropic support but has continued deterioration in nutrition, renal function, fluid retention, or any other major status indicator. Patient is refractory fluid overload despite inotropic supports. Intermax 3 is when you have a stable but inotrope dependent patients. These are all patients who are there in the ICU with mild to moderate doses of IV inotropes, or they might require a temporary circulatory support like a VA ECMO or a Centrimac. And the Intermax 4 is patients resting symptoms on oral therapy at home. So any patient who's coming in this category, Intermax 4 and 5 and 6 and 7, are actually the right candidates, and these are the right patients who should be referred. But what we see is that the patients who are Intermax 1, 2, 3 are the ones who really get referred when they are in the ICU, crashing, burning, and with fired organs. So what my take-home message for everyone is that if a patient is in heart failure, you have the listed criteria that the ejection fraction is low, biventricular failure, non-viable myocardium. These patients should be listed for a transplant a little earlier than later. There are also etiological indicators. I'll just run through them. I categorize them into two: ischemic cardiomyopathy and non-ischemic cardiomyopathy. Ischemic cardiomyopathy, as you would know, is any patient with coronary artery disease, diffuse coronary artery disease, which we can't revascularize. Very important to note here is there should be proven absence of reversible ischemia. And also, as I said, right ventricular function should be noted. It should be less than 35%. We normally get a cardiac MRI done, which shows biventricular function. And all the volumes are also very nicely demonstrated on the echo. We also have a category called non-ischemic cardiomyopathy, like dilated cardiomyopathy. It could be patients with viral myocarditis and the myocardium just gets burnt out. There could be hypertrophic cardiomyopathy, restrictive cardiomyopathy, and as I mentioned before, incorrectable congenital heart disease and valvular heart disease, which is a big group which should not be discarded. So ischemic cardiomyopathy, very important of understanding the concept of reversible ischemia. See a patient coming with 10, 15, 20, 25% ejection fraction also can be revascularized, and that patient can have a very good benefit if you are able to prove that the underlying substrate is viable. So I wrote this book chapter in this Cardiology Today on this problem of reversible ischemia and heart failure, which is an under-recognized problem. So there is criteria which are laid out, and I'll just go through this on this side of the screen. If you look at it from out here, there are a few major and minor criteria. So if you have a left ventricular wall thickness less than or equal to 5 to 6 mm, there is no response to low dose dobutamine echo, that is a stress echo. SPECT is negative, that is the PET scan is negative for viability. Your cardiac MRI shows low gadolinium enhancement is more than 50%, and the PET is also negative for hibernating myocardium. So these are major criteria. Minor criteria: left ventricular ejection fraction less than 20%, LV volumes. It could be more than 200 ml per meter square for the left ventricular end diastolic volume, and systolic volume more than 120. By angio, by echo, it is 170 and 90. And the dimensions for left ventricular end diastolic dimension more than 5.5 centimeters square. So any of these combination, if it's more than 4 major, then the chances of this LV, even after revascularization, are not likely to improve. So I use this criteria to make a judgment whether my regular coronary artery patients like this, who present to the left main with an ejection fraction of 15 to 20%, deserve myocardial revascularization or not. So you'll find that this patient has been evaluated. He matches the criteria of viability. And on table with arteriographs, you can see that the LV function actually improves. Now, in an Indian spectrum, what happens? What are the kind of patients we see? This is Dr. K.R. Balakrishnan, who's got the highest series for heart transplants in India. He's from Chennai. And what he's shown is that 56% of our population has dilated cardiomyopathy, 17% have ischemic cardiomyopathy. Now, if you look at previous CABG and PCI, this is a big substrate of patients who might be coming to any of your OPDs who have had bypass surgery or an angioplasty. These patients should be closely watched with echoes as well as your regular medical treatment. Optimal medical treatment should be given to these patients because as I will show you a little later, you'll find that if these patients are lost to follow-up, for example, this patient had done a heart transplant, 21 years post CABG, he had functional grafts, but he had reduced ejection fraction and developed end-stage heart failure. Basically, he was lost to follow-up, didn't take any medicines. He came just 6 months before the transplant with this scenario. But if you see, the grafts are patent, but the patient has got ischemic cardiomyopathy. So this is one subset. Then you have a patient who's had an angioplasty, again lost to follow-up, 2021, within 6 years, he comes with LV aneurysm, LV apical clot, and he is listed for a transplant. And that is the same patient who you saw on the bicycle ergometer. This is the most common subset of patients, dilated cardiomyopathies, which we see a normal LV on the left side,
You have
dilated
last 2-3
cardiomyopathy on the right.
minutes for your
Yeah,
talk.
I'll wind up, madam.
Yes,
So,
thanks.
and then you have this congenital heart disease patients. Again, all these patients have to be aligned with what you're doing in terms of clinical practice and the heart failure symptoms. This is restrictive cardiomyopathy. So I'm just showing you live cases of what I have operated on and how they present. And what I have noticed is that the stage of referral is very, very late. For example, There is no need for this patient to come who has got restrictive cardiomyopathy. There's such a huge RA clot. You can see the clots inside the right atrium. The LA is calcified. What I'm trying to again and again emphasize is that it's very important for us to have early referrals. Now, sometimes when you delay the referrals, you have irreversible pulmonary artery hypertension like this, where the pulmonary vascular resistance goes up. The patients sometimes have end-stage renal disease, end-stage liver disease, and then the timing of heart transplant goes off center. This is a book chapter I wrote for the Heart Failure Society. And in this, it's very important for us to understand this. I'll just wind up in a couple of slides, madam. The early referral is important. So that is NYHA 1 or 2, tolerating GDMT, no hospitalization, no evidence of end organ damage. This is the ideal patient, but it's okay. The golden window for referral is this one: NYHA 3 or 4, down titration or inability to tolerate GDMT, frequent hospitalizations, recurrent arrhythmias, ICDs, and worsening renal function. And these are the patients which we have to face day-to-day practice, with multi-organ failure because of late referral, severe malnutrition, cardiac cachexia, and they have pump failure and death even before they come. And this is an example of creatinine. If it goes to more than 1.5, the chances of post-transplant mortality jump up by 10 times. So I like to leave you with these thoughts and a take-home message that early referral to an advanced heart failure unit is a key for success in heart transplant surgery. The option for heart transplant surgery should be initiated early in the conversation with the patient rather than late in the ICU. And a patient with stage D heart failure who's an ambulant condition with preserved end organs is the best candidate for a heart transplant and what we call the golden window for referral. Thank you very much, madam, for having me over. And I hope I've not gone over time. And
No, no, absolutely not.
I'm okay with questions if people have. But thank you for bringing us to the notice that adiposity, obesity is the root cause for what we are seeing in our day-to-day practice in heart failure. And thank you for once again for having me over.
Okay, thank you so much, sir, for the very nice and crisp presentation. Do we have any questions from anyone?
Sir, hello, Dr. Parmeshwar here, sir.
Yeah, Dr.
Surgeon. My question to you is sir, if the window permits, do you consider the GLP-1 medication or bariatric surgery in a patient with morbid obesity who are in the line for such surgeries?
See, I don't know. It's a double-edged weapon, I'm sure, because see, I personally feel if you are looking at the heart as an engine where you need to first treat a patient with end-stage heart failure, I think I would go for that first. And most of these patients, they normally are not obese. They are really malnourished, cachexic. So I would be very happy to see a patient who's got to that stage where, but I would prefer a little bit of obesity than cachexia. And I would like to do the heart transplant first and make the patient fit for any other procedure later. If that answers your question.
Thank you, sir. Thank you, sir.
Thank you, sir. So let's move on to our next session by Dr. Khushbu Verma on obesity care in GLP-1 era. Welcome, Dr. Khushbu. Okay. Khushbu Verma, you're not audible. You're not audible, ma'am. Uh, you are still not audible. So it looks like there must be some technical glitch. Till that time, I'll just tell you about the topic what we are discussing with her. We are going to discuss about the obesity care in GLP-1 era. So what is the role of the technology and the multidisciplinary follow-ups what we need in the management of obesity? That's going to be a very interesting topic in this era where we have devices to monitor our sugars and our inflammation and BMI and everything. So let's see what she has to talk on it. Miss Khushbu, can you just unmute yourself now?
Am I audible now?
Yes, ma'am. You are audible. Yeah, thank you.
Super.
Yes.
Yes, super good.
Yeah.
Thank you so much and sorry for the glitch. I hope there is no echo or anything.
No, absolutely clear. You can
Okay,
go ahead.
all right. I'll just share my screen again.
Yes.
So first of all, I thank Dr. Reema for giving me the opportunity and the organizing committee uh, for this opportunity to speak here. This is an introduction slide. I will just skip this quickly because and am I still audible?
Yes, you are audible, ma'am. Go ahead. Yeah. Okay. We have lost your voice again. No.
Okay, is it better now?
Yes, we can.
Okay. So just to highlight that I have 22 years of experience in digital health in from different countries, US, UK, Canada, Finland, Denmark, and India. And with all this experience, what I feel is that there is an important aspect that can be solved with technology and with digital health. My previous speakers, Dr. Reema and Dr. Manoj, they highlighted something very important, which I would like to continue in my session, in my lecture as well. And these two things were mainly importance of multidimensional care to address obesity, which Dr. Reema mentioned, and the importance of avoiding patients lost to follow-up, early referrals, and preventive care, which Dr. Manoj highlighted. So I'll continue with those two themes actually in my presentation and try to explain and share my experience that how technology can play a role in this. Uh, Having worked with chronic care and longitudinal care delivery, technology plays a very important role, and obesity is one of the areas, especially in GLP-1, where multidisciplinary follow-up becomes even more important. What we are seeing today that our clinicians, our nutritionists, our physicians, they are expected to move from episodic treatment to continuous care, which is more data driven. But do we have access to such data? Do we have access to that structured protocol so that we don't lose the patients and make the decisions half-baked with less information than what is expected by especially these incretin-based treatments? The new reality is circling around a multi-dimensional follow-up, multi-dimensional data collection. But is it possible for a clinician to take care of the entire purview within the consultation time? A lot is happening in between consultations. And obesity care, especially with incretins or GLP GIPs, like Dr. Reema mentioned, it demands this focus on every aspect of care. It needs continuous monitoring, nutrition optimization, muscle mass preservation, physical activity coaching, side effect management, behavioral change, and on top of that, mental health with weight maintenance as well. So these aspects are really difficult to only take care of from one consultation to another, and that is where technology comes into picture. If you have the right platform for your support as clinicians, you can do a lot in taking care of these dimensions in a very automated way, very simplified way, and presenting you the right data during the consultations, or also creating alert for patients and doctors in between consultations. And that is what we are passionate about doing. The biggest challenge is not, of course, prescribing GLP-1. Every general physician, diabetologist, endocrinologist are prescribing GLP and GIP today. And this is something we have been doing, or I have been personally experiencing for last 4.5 years, because in Denmark, GLP treatment started even before. So we collecting those experiences and learnings, we understand that there is lack of adherence. There is a huge risk of loss to follow up. There is huge risk of lack of motivation as well from the patient side. At the same time, from the clinician side, they get a lot of interference in terms of sending reports, sending symptoms on WhatsApp, and also lack of multidisciplinary coordination if you don't have a big team of taking care of these GLP patients. And the gap isn't about clinical knowledge, it's about absence of a system that carries care between visits. So, what we have learned from Denmark and countries where incretin-based treatments have been popularized much before, is that it cannot be managed by one clinician. It generally needs a group of clinicians, a group of, if be it endocrinologist, dietitian, diabetes educator, exercise specialist, psychologist, care coordinator, and also family and caregiver. And this becomes an impossible task to coordinate among this and have such a big group everywhere with each doctor, with each clinic, with each mid-sized hospital. That is where technology comes into picture. Whatever gaps you see in the care delivery, that can be easily fulfilled by technology today, which means that uh, one specialty empowered with others using technology is the idea, which means that one shared patient journey, one holistic care delivery, one holistic care provider, assisted by technology for whatever is remaining. Uh, on top of this, GLP care and obesity care, it demands continuous care, not only episodic. And it goes with a lot of chronic diseases, but because it's an obesity conference, I'll talk mainly about GLP treatments and obesity. But I believe that longitudinal care is the key to handle all chronic diseases. And consultations are the most important part of it. But in between consultations as well, there has to be a continuous care loop, which means that the patients have to get personalized care plans. They have to have engagement in their own care. They have to be actively present and engaged with the care. They have to be monitored, but also educated and empowered to make the right choices. And then they have to get, both the doctors and patients have to get the right risk alerts at the right time so that they can do this timely intervention, and so that when the next consultation comes, the patients and doctors both are prepared with complete data. So that is where this continuous care loop uh, plays a role. And especially in obesity care, it becomes very important. This is something Dr. Rima mentioned as well, and I was so happy to hear this, that body weight and BMI are not the only indicators. Uh, there has to be a platform for the entire multidisciplinary follow-up, which takes care of the clinical aspects, which includes weight trend, BMI, glucose, triglyceride levels, like Dr. Manoj mentioned, but also it can have BCA related data, but also it has to include nutrition, lifestyle, and patient reported data.
Okay.
Uh,
Khushbu, last minute.
okay, super. Thank you so much. So, again, technology can room this much information. Human brain cannot. And that is where it becomes, in the new reality of GLP-1 care, it becomes really important to use technology in the right manner to take care of these multidimensional, all these aspects. I'll just quickly go through the remaining slides just to make the important points. Technology should reduce workload and not create more. So whatever technology you use in your practice, it should not be fragmented. It should not be multiple platforms. It should be something which delivers easiness and quality in your care delivery. On top of that, now that the role is becoming towards more continuous coaching towards the patients and also their families, it's important that the technology that you select helps you in that area as well. And I think GLP-1 becomes then only one part of the treatment and not the entire treatment. So the comprehensiveness comes from the other aspects. GLP-1 becomes one part of the treatment, the therapeutic part, like Dr. Rima shared as well. I'll just end the presentation with this, that the end-to-end pathway for GLP-1 patients, for uh, incretin-based treatment, it's very important that patients are involved, they are educated, they are empowered, and then they are monitored in a way that we can complete that continuous care loop towards our patients. And this is where technology platforms can help you. So with that, I will just stop sharing. And if there are any questions, please do ask, and I would love to answer them.
So it was a very good presentation. We as clinicians are very less advanced related to the technology. So one question I have, so how might AI and predictive analytics personalize obesity management in the future?
Yes, a very good question, Dr. Kritika. Thank you so much for that. So I would say first thing about your first point, that technology should be an enabler to the least tech savvy clinicians. It should be made so simple. It should be the slave and not should be the master. The technology, and that is what we focus on Cordia as well. That the platform, the Cordia, it does not decide how you work. It should transform the way, transform it itself in the way you want it to work. So keep having that master slave relation clear between the human, between the clinician and technology is very important. It has to be very easy and intuitive and has to behave the way you want to. Coming to the second question, predictive analysis. It is an important part of care delivery today because, like Dr. Manoj was also mentioning, how do we ensure that the patient comes uh, before it is too late? And that can be done with predictive analysis. And AI, if the data is given to AI in a proper way, to the technology in proper way, then platform like ours, they predict that if the measurement has been like this in last 5 times, how is the next measurement going to be? That's very easy to predict. It's regressive. There are some algorithms that can very easily do it in a very validated manner. So I would say that predictive analysis plays a huge role, and we should start employing technology in our care delivery so that we can harness the power of data. We can harness the power of AI in true manner. So
Thank
yeah,
you. Thank you.
thank you so much. Thanks a lot.
Okay.
Moving on to the next session, we have with us Dr. Ashok. He will be talking about heart failure in obesity without diabetes. Welcome, sir. Please start your presentation. Ashok sir?
I think he's not online. So we'll move on to the next
Yeah,
one.
we will move on to the next session. Our next session will be about precise diet strategies in chronic nutrition, protein and optimization, and microbiomes. It is presented by our Dr. Anu Mahajan. Hello. Yeah, hi. Am I audible, ma'am? Dr. Anu Mahajan.
Okay, I think
Yes.
our speakers may be somewhere busy. So we'll run one online. Okay, we'll go with one session on long-term durability of sleep plus procedure for obesity and diabetes by Dr. Tometaka Yunio. He would be talking for about how this helps in obesity.
So I am Dr. Parmeshwar. Bueno is my good friend from Tokyo. So we were colleagues in the YMC hospital. We are running the video because she is not available.
Okay. Okay. Thank you, Dr. Tomataka. Now, let's go on to our next session by Dr. Anu Mahajan. She would be talking to us about the diet strategies, which is very important topic, how to manage the obesity, on chrononutrition, protein optimization, and microbiome. Welcome, Dr. Anu. Over to you, ma'am, please. Ma'am, you are not audible.
Hello, am I audible, ma'am?
Yes, you are. Hello,
Okay,
welcome. Welcome.
Thank you so much. Can you please help me with the presentation?
Yes.
Thank you. Shall we start?
Yes, ma'am, you can start.
Okay, so good evening, everyone. I'm Anu Mahajan, and today I'll be speaking on precision diet strategies, chrononutrition, protein optimization, and the microbiome. So rather than discussing another restrictive diet or any standard weight loss plan, I will be focusing on three clinical applicable strategies that will help us to personalize the nutrition according to an individual metabolic pattern, lifestyle, muscle health, and gastrointestinal tract. So, before proceeding, I would like to introduce myself. My name is Anu Mahajan. I hold double postgraduate degree in pharmaceutical sciences and clinical nutrition, as well as a doctorate in clinical nutrition. I I have published 14 research papers in various prestigious journals, and my clinical and research interests include type 2 diabetes, insulin resistance, metabolic disorders, gut health, and women's health. Through my clinical practice at Healthify by Anu, as well as my academic and research work, I have observed that patients with apparently similar weight or glucose levels respond differently to the same dietary prescription. So that is why I am just talking about here about the precision nutrition. So can you please move the slide forward? Yes, thank you. So why precision nutrition now? So for many years, weight management has been dominated by a clear and a simple message, which was eat less and move more. Though energy balance remains important, but the approach assumes that the same calorie deficit will produce an identical response in every individual. In clinical practice, we know this is rarely the case. Two people may consume same amount of the calories, but they have different type of experience. The traditional approach focus on calorie counting and the standard recommended dietary allowances. However, precision nutrition asks additional question like at what time patient is consuming most of his calories. Are they consuming enough amount of protein to preserve their muscle mass? Are they taking enough amount of fiber intake, or they are having a low dietary diversity, are they are shift workers, or or they are taking any kind of oral hypoglycemic agents or insulin which can increase the risk of hypoglycemia. So the paradigm combines diet quality, meal timing, nutrition distribution, clinical phenotype, and the individual biology. Next slide, please. So in this presentation, I will discuss 3 practical clinical levers. The first one is chrononutrition, where we align food intake with the body's circadian rhythm. The second is the protein optimization, where the objective is to preserve the lean mass, improve satiety, and support glycemic stability. The third is microbiome strategy, where we improve the diversity of the fiber and plant foods to support microbial metabolism and short chain fatty acid production. So, in practice, these translate into 3 simple assessment: a timing audit, a protein dose assessment, and evaluation of the fiber diversity. Next, please. So the first lever is chrononutrition. So chrononutrition examine the interaction between the food intake and the body's internal biological clock. During the morning and the active phases, insulin sensitivity, diet-induced thermogenesis are generally more favorable. The body is physiologically prepared to receive and utilize energy. However, when a major portion of daily calories is consumed late at night, food intake becomes misaligned with the circadian rhythm. This mismatch may contribute to the poor glucose tolerance, disturb appetite regulation, and greater difficulty in controlling the sugar levels. So consider a patient who skips breakfast, has tea and biscuits during the day, eats a moderate lunch, and consume the largest meal at around 10 or 11 at the night. Even the calories intake seems to be reasonable. However, the timing pattern may be metabolically unfavorable for this patient. So the prime practical objective is to front load a greater portion of the calories and protein earlier in the day and reduce the late night calorie intake. So this does not mean that every patient must follow this extreme fasting protocol. The first step is often much simpler. Like we can finish the dinner earlier, reduce post-dinner snacking, and create an consistent overnight fasting schedule. Next slide, please. So, how do we translate the chrononutrition into a practical clinical perspective? We can simply begin with a 12-hour fasting window. For example, finishing the dinner by 8 p.m. and in the morning, taking the first meal at around 8 a.m. The second step is to establish protein rich breakfast. So like rather than having tea biscuits in the morning, we can replace it with a protein rich meal. Third is third aim is to have an early and a lighter dinner, preferably completed 2 to 3 hours before the sleep wherever it is feasible. Fourth, 10 to 15 minutes walk after a carbohydrate heavy meal can be a simple and an acceptable method of reducing the post-meal glucose excursions. So the clinical rule is move dinner earlier before shortening the eating window. So safety is also essential. So we have to review if the patient or the person is on insulin or sulfonylurea, the dose has to be regulated one. Aggravative fasting is not allowed or is favorable in case of pregnancy or with any eating disorder patients. And very importantly, shift workers needs individualized windows depending upon their sleep and awake cycle. And very important is to track their glucose levels during this transition. Next. So the second lever is protein optimization. So during weight loss, the objective should be reducing the fat, not reducing the muscle mass. A person may be pleased with the weighing scale just moving downward, but if a significant proportion of the weight loss is the lean tissue, the long-term metabolic outcomes may not be favorable. So loss of muscles can reduce the functional capacity, they can even lower the energy expenditure and even likely to regain the weight. So protein supports the lean mass preservations increase satiety and may reduce the magnitude of the post-meal glucose spikes when the carbohydrates are paired along with the protein source. So the baseline recommendation, as we all know, is the 0.8 grams per kg body weight, and it can be increased to 1.2 to 1.6 grams per kg per day, depending upon the clinical status. However, total protein is one part of the prescription. Distribution is equally important. So instead of consuming a very little protein in the breakfast or the lunch, the protein should be equally divided. For example, a practical and a targeted approach should be like taking 25 to 30 grams of the protein at each and every meal. And the cultural transitions, we can upgrade it with very smartness, that we can replace the traditional breakfast like poha, idli, or even tea biscuits uh, with besan chila, moong dal chila, curd, paneer, eggs, sprouts, or yogurt, like this kind of things. Lunch can be, simply dal combined with paneer, curd, or salad, and with a very controlled portion of rice and roti. Snacks in the same way can be a chana, makhana, okay, and with the Greek yogurt also. So dinner should be light earlier as much as possible and reducing the total cereal load. Next slide, please. So the third lever is the microbiome. So food which we eat does not interact only with the human cells. A portion of the food which we are consuming also act as a substrate for the microorganism living in our GI tract. The objective of microbiome focused dietary strategy is not simply taking a probiotic capsule. The broader goal is to increase the diversity of the plant fiber and the food substrate available to the gut microbiota. So we can increase by including prebiotic fibers from the pulses, oats, seeds, adding resistant starches, getting a good amount of polyphenol sources from colorful fruits like berries, amla, adding spices, uh, even adding fermented foods like curd, kanji, idli, dosa, so that to ensure a good microbial strength. So these microbiota, they converts the substrate into the metabolites such as short chain fatty acids. These metabolites supports intestinal barrier function in influencing the inflammatory signaling, participating in the metabolic pathway related to the appetite and the GLP-1 activity also. Okay, so one very important thing is to increase the fiber slowly. It is not like that increasing all the fiber in the very first prescription. Take it slow, taking 5 grams of the increasing 5 grams of the fiber every weekly with a good amount of hydration so as to prevent the bloating for that person. Next. So this slides bring all the three levers together. The precision nutrition begins by identifying the dominant patient signal and matching it with the appropriate first intervention. For a patient with late night dinner and fasting hyperglycemia, the first step should be chrononutrition. For a person who is experience high hunger and have low protein breakfast, we can include more protein. With constipation, we can work on the dietary fiber. And if the person is having the sarcopenic obesity, including protein along with the resistance training exercise will help. For shift workers, it is very important that we have to manage according to their timing, their sleep and awake schedules. Next, please.
Ma'am, you have last 2 minutes.
Yes, I'm just finishing up. So this is like a 2-week precision starter protocol. So, start with the simple things like including a 12-hour fasting window, ensuring the protein distribution throughout the day, adding one fiber serving per meal, and personalizing it to moving the dinner time a little bit earlier, and stick to the 10 to 11 hour of the fasting schedules, rather moving to the extreme 14 or 16 fasting schedules, and adding a good amount of the fiber diversity. Next, please. So the take home message is to first align eating with the circadian rhythm by reducing the late calorie intake and encouraging a earlier and lighter dinner. Secondly, protect the muscle mass with adequate protein, including the dose distribution and resistance training exercise. Third is feeding the microbiome through giving a good amount of diverse fiber. And most importantly is to choose the liver according to the patient phenotype and keep the plan simple enough to follow. So the best dietary prescription is not the complicated one. It is the one that addresses the patient's primary metabolic barrier that can be sustained in his or her daily or everyday life. Thank you so much.
Okay. Thank you, Dr. Anu. I would like to know one thing. So can this chrononutrition can improve the efficacy of anti-obesity medications?
Yes, it can. The chrononutrition will help. Like, if the person is eating it at at the late night, so it will be difficult to manage the hormones level. Take care, regulate the hormones level. So GLP-1s are what? They are like a hormones analog. So if you are not first balancing the hormones through a natural way, through a dietary regime, then how can we expect that it can be improve only through the medication? So if we can first try with these personalized nutrition or the precision nutrition and then combine it with the medication, then the combined effect will be much more better.
Okay. Thank you. Thank you for your wonderful insights. Hope it will protect many, it will give many insights to other doctors also who are looking for weight loss. Thank you.
Thank you.
So moving on to our next session.
Next session will be by Dr. Shailaja Mehta. Rajali Mehta. So it is about early obesity, puberty and obesity, and biodirectional endocrine crisis in modern pediatrics. So over to you, ma'am.
Thank you so much for your kind introduction. So can you share my slides?
Yes, yes.
Okay. So I'll start my session now. So
Yes.
today we are going to discuss about two important topics, early puberty and obesity, which we are facing a lot in pediatric patients. So we are talking about this during, I am not able, can we go to the next slide? Okay, so by the end of the session, what are we looking at is we are trying to learn the physiology, how the HPG axis works, and what is the role of leptin in this. We will see what are the criteria to diagnose early puberty and what are the obesity-related confounders. We will summarize some findings from the large cohorts that we have seen, which addresses this link, and then we will be talking about the management approach. So next slide. So there are 5 parts to the story. First is the physiology and the leptin, then the mechanistic link. Then we'll be discussing about the diagnostic criteria, what and how to diagnose early puberty and what management is to be done. Okay, so let's go to the next slide. So let's understand part 1, that is the physiology. So we all know the hypothalamo-pituitary gonadal axis. The hypothalamus is normally where the Kiss peptin neurons or Kiss1 neurons are there, which are the main or the earliest biochemical signal for pubertal onset. The Kiss neurons are quiescent during the childhood period, and when the body is prepared to move to the next stage, they become awake and they drive the pulsatile GnRH secretion from the hypothalamus, which initially is in the night initially, and then it becomes diurnal. This GnRH neurons secretion acts on the gonadotropes to secrete LH and FSH, which progressively increase in the amplitude. The gonads then respond to this LH and FSH and cause production of estradiol and testosterone, which brings about the clinical changes in the kids. Okay. So what is most important is the axis is quiet during the childhood period because of the central inhibitory tone. The reactivation timing is normally programmed by the genetics. Okay, but here is where the obesity and other metabolic signals play a role, where they can cause a shift earlier in this activation, resulting in precocious puberty. Next slide. So what is the role of leptin in puberty? So we know that leptin is secreted by the adipocytes in the fat mass, and it is in proportion to the amount of adipocytes or fat mass that are present. So when the fat mass is adequate, the body signals the brain that there is sufficient energy in the body to progress to the next stage. That means that the body can progress to a next stage where there will be more energy requirement. So basically, it is necessary, but not only a sole indicator or sole activator of HPG axis. There are various studies which have done that shows that leptin has a permissive role. We know that clinically also in patients who are athletes, in them the puberty is delayed because they have less fat mass compared to other population. Also in patients who have anorexia nervosa, even when they have been initiated or they have had their menses, the menses stop when they go in anorexia nervosa because of the critical loss of the fat mass, and their axis becomes quiescent. And in those patients with treatment or adequate gain of fat mass, the axis reactivates. So this all helps us to understand that the leptin does have a role in obesity, though it is not a sole role. Can we go back? Okay. So what happens in obesity? When the child is chronically obese, there is elevated leptin levels, which actually cause early sustained signal to the hypothalamus, along with other convergent inputs that advance the pubertal switch by 1 year or more. So when you have a lot of fat mass, there is early onset of puberty. And let's go to the next stage. Back. Can I go one slide back? Okay. So the basic mechanistic pathway, if you see here, is from the adipocytes, the leptin is released, which acts on the arcuate nucleus on the Kiss1 neurons, results in secretion of Kiss peptin, which then acts on the GnRH neurons, causes production of LH-FSH, and which acts on gonads to produce precocious puberty hormones or the sex steroids, which brings about precocious puberty or puberty in the children. In children with obesity, the signal is not only delivered early, but it is also more intense. What does that mean is, if the progression of puberty normally happens over 3 years in a child, in an obese child, it may progress rapidly. In a span of around 1.5 years or 2 years, they may get menses. So it not only causes early puberty, but also the progression is very fast. Okay, let's go to the next slide. So we know that obesity-driven early puberty is there, but what are the pathways? As we discussed previously, we know that leptin causes signals Kiss peptin to produce early GnRH hormones. In addition to that, there are other pathways also which drive the puberty. Because of obesity, we know there will be insulin resistance, which will increase insulin levels in the body, which can amplify the GnRH pulsatility. And also IGF levels will be increased, which will correlate with the testosterone and pubertal tempo. In addition, obesity, we all know, is inflammation. So the inflammation can activate microglia in the brain, which can prematurely activate the GnRH neurons. And in addition to that, the adipose tissue or adipose tissues or adipose cells do not only secrete leptin, but they also have other enzymes which can convert androgens to estrogens, causing increased estrogen exposures in female, and this all together can advance puberty and also increase the tempo of puberty in girls. In boys, the aromatization may cause gynecomastia, in boys, but not advancement in the puberty. So these are the various pathways in obesity which can drive the puberty early in kids. Next slide. So what happens in males and females because of obesity? So in girls, it has been consistently shown that it accelerates puberty because of all the convergent factors that we described previously. But in boys, the picture is inconsistent. In some conditions, we have seen that some boys may have early puberty, or some studies show that some boys go early in puberty, but majority of them shows that the boys actually have delayed puberty. Or obesity can cause gynecomastia, but decreased or staggering puberty in boys. So the picture is mixed, but yes, it does affect the puberty in boys as well. Next slide. So what are the diagnostic criteria to confirm central precocious puberty? So we need clinical criteria, biochemical, and the bone age or imaging studies. So basically, clinically, we define precocious puberty as early on breast development or thelarchy before 8 years of age in girls, and increase in testicular volume of more than 4 ml in boys before 9 years of age. Also, if the menses come before 10 years, we consider that as early puberty. So if any of these clinical features are present, one must evaluate this child. Okay. And the most common thing that, or the blood test that we do to confirm pubertal onset is serum LH levels, FSH levels, and estradiol levels. LH levels, basal LH level of more than 0.2 is significant enough to suggest that puberty has begun in the child. In some conditions, when the clinical picture and the GnRH basal levels do not correlate, one can do a GnRH stimulation test where the peak LH of more than 5 is considered as a standard to consider central precocious puberty. In addition to that, we also have bone age. So basically, bone age tells us about the age of the child internally. So most of the times, because of the testosterone or androgen exposure, the bone age is advanced in these patients who have central precocious puberty. Okay. So this is how clinical, biochemical, and bone age will help us identify early precocious puberty in children. What happens in girls with obesity? There is an obesity confounder, which means the peak stimulated LH in the Tanner stage 1 and 2 and 3 is measurably low than compared to normal weight peers because of the BMI blunting effect on the LH levels. So in conditions where we are in doubt, because of obesity, we are not able to understand whether the child is in puberty or not, because the levels may not match the thresholds. One need to wait clinically, considering the clinical staging and also bone age advancement. Then interpreting only borderline GnRH analog levels. Okay, next slide.
Ma'am, you have last 2 minutes.
Yeah, fine. So these are some studies which have been done, which have suggested that yes, that early puberty is correlated with obesity. And it is a consistent reproducible risk factor for early precocity in girls, whereas in boys it shows mixed picture. Next slide. So even this is a study in which the mouse who was deficient with leptin, and when administered leptin, showed to go in puberty. So this further confirms that leptin does have a role in pubertal progression. Next slide. So thus we know that puberty also has effect on obesity. So what is the reverse arrow is here, that when pubertal hormones cause physiological insulin resistance, or the sex steroids cause physiological insulin resistance, and which can predispose the child to gain more weight, predispose the child to a pre-existing metabolic risk. Or they may manifest with type 2 diabetes if they have the risk prior, or they have impaired glucose tolerance. Okay. Even the treatment that we use for puberty, that is the GnRH analogs, they also have shown to increase body fat mass and insulin resistance. Though the data is limited, but yes, GnRH do affect the metabolic factors. And it has also been seen those girls who go early in puberty, they tend to have adult onset obesity at higher risk of adult obesity. Next slide. So it's a bidirectional thing, and it needs a prolonged multi-pronged management. The first and the most important management in this is lifestyle. In pediatrics, lifestyle plays a very important role. Prevention is better than cure, but if the child is obese, still we can give them physical activity and nutrition counseling, which can help them to lose weight and does improve the pubertal progression. In addition to that, if the child is in central precocity, we can start them on GnRH analogs, which will delay the menses and also give height benefit if they are started before the age of 6 to 8 years. And in addition to that, they need to be monitored frequently because obesity and puberty, as we discussed, are interlinked. We need to track their BMIs, we need to check their insulin resistance, lipid profile during the treatment, so that if any problems arise, we can treat them or address them at earliest. In addition to that, we know that sleep is an important regulator of the GnRH rhythm. So adequate sleep is important, and limiting exposure to the endocrine disrupting chemicals is also important, and the parents must be made aware of this. A multidisciplinary team addressing the mental health issue is also important. Next slide. So the key takeaways from this are that puberty begins when the kisspeptin reawakens the GnRH pulse. Okay, leptin is a permissive gatekeeper. It is necessary but not solely sufficient for pubertal onset. Obesity blunts the peak LH response on GnRH stimulation testing, so clinical staging is important. Puberty's own insulin resistance and GnRH metabolic effects can further amplify obesity and should be monitored for. And management requires lifestyle intervention, judicious use of GnRH analogs, and a coordinated metabolic care. Thank you.
Yes. Thank you, ma'am, for your insights on obesity and puberty. I would like to ask, what are the long-term reproductive and cardiometabolic implications of early puberty?
So, long-term implications, like, see, if there are puberty is secondary to obesity and other causes, then there is a risk of metabolic diseases that we see in patients, and also there is a risk of obesity. As I discussed, if the child has precocious puberty, the risk of obesity also increases. So all these things can overall increase the metabolic complications leading to cardiovascular events and all.
So, yeah.
So reproductive wise, if you ask, if the child was early in puberty, the chances for female especially is to have early menopause also. The premature menopause also can occur in females because of early puberty.
And what role do ultra-processed food and sugar-sweetened beverages play beyond excess calorie intake? So calorie intake is there, but what excess other than that?
Yeah, any high refined foods do trigger inflammation in the body. A low-lying inflammation and also can trigger early puberty, as we discussed previously.
Okay.
So yes.
All right. Yes. Thank you, ma'am, for your joining in. Yeah, thank you.
Thank you.
So moving on to our next presentation by Dr. Tripti Dev. She's there, and she's going to give us information and knowledge on the new drug for HOCM mavacamten. Over to you, ma'am.
Thank you very much, Rima and the entire team. And it is going to be a very interesting topic because I would like to say that why mavacamten is so important. It's a very new drug. Can you hear me, ma'am? Hello?
Yes, ma'am. Yes, ma'am, we can hear you.
Can you see my PPT?
Right. Yes, yes.
Yes, bolche PPT. They can see my PPT. Is it visible, ma'am?
Yes, absolutely, clearly.
Yeah. So, can you tell me, it is clear, no? Okay.
Yes, it is clear. Yeah.
Okay. So, I would like to tell you about this new drug, mavacamten. Why it is new? Because it was in the pipeline and going through a lot of investigation and the research and the RCTs. And finally, it got approved by our FDA last year in March. And now we have been using since last year to reduce the septal thickness. Now, if I come to the next slide, then I can tell you what exactly I'm going to talk about this mavacamten, which is a wonderful drug, and it shows that that how we can proceed to use this drug as a completely new modality to improve the hypertrophic obstructive cardiomyopathy, not only the symptoms, but the disease and the pathophysiology, as well as the anatomical detailing, which can be reversed. I never saw such drug in my last 40 years of clinical practice, which can reverse the anatomical pathophysiology without any surgery. and without any intervention, just by a drug. That is marvelous, actually. I would like to go through like basic epidemiology of HOCM, pathophysiology, diagnostic pathway, then current Explorer and the Valor trials, which are important for the efficacy and the safety of this drug, which is questioned often. Now coming to the next slide. Next slide, move ochina Gautam. Gautam? Next slide, move ochina. Okay, sorry. Now coming to how it works and what is the epidemiology of HOCM in not only in India, in the world. So hypertrophic cardiomyopathy is estimated to impact 1 in 200 to 1 in 500 adult, and looking to the Indian population, you can see the burden of HOCM, which is actually undermined totally. We are in an iceberg, and the tip of the iceberg only we can see, and mostly we misdiagnosed. 80 to 90% remain undiagnosed. Two main subtypes of HOCM are obstruction, that is obstructive cardiomyopathy, which represents 50 to 70% of all hypertrophic cardiomyopathies, resting to provoke LVOT gradient of more than 30 millimeter Hg, and thickening of the ventricular septum, which decreases LV volume and narrows the LV outflow tract, reducing the blood flow. So, in non-obstructive cardiomyopathy, we have cardiac wall thickness without obstruction to the LV outflow tract. So, hypertrophic cardiomyopathy is a genotype, which is the presentation of genotype is actually completely dominant type of genotypic presentation, but phenotypic presentation may differ. That is 30 to 40% of the patients with phenotype of HCM have a known pathogenic mutation. Some individuals can be genotype negative but still express the phenotype, while the others can be genotype positive but not express the phenotype until later in the life. So it can present early in the life or it can present later, though it is an autosomal dominant inheritance. Now coming to the pathophysiology, that what happens in our heart muscle cells, which is a very unique muscle cell which is automatic, and automatically it keeps on automaticity and keeps on contracting without our knowledge. So what is the sarcomere? Sarcomeric dysfunction. That is, myocardial cell is known as sarcomeric dysfunction in hypertrophic cardiomyopathy, which leads to excess myosin actin cross bridging. That means the activation of the myosin and actin is in excess contractility in the right side of this image. And then when it is active, that is in the normal contractility, it is only 40 or 50% engaged with the actin myosin contractility bridges. Now, if hypertrophic cardiomyopathy sets in, because of the genetic variation, it is almost completely engaged. That means so many myocytes by actin myosin are contracting together, causing a hypercontractile state, and this causes impaired relaxation of the heart muscle and the hypertrophy, as well as poor compliance. That is, most of our patients of hypertrophic cardiomyopathy without obstruction will have a heart failure of preserved ejection fraction and disordered sarcomeric length as well as contractility and the engagement with the actin myosin compartment and cardiac tissue stiffness with fibrosis. So these are the basic pathophysiology. If you see now exactly what happens at the ventral septal thickening level, normally when we have only normal heart, there is no hypertrophy as well as there is contractility is normal and there is no thickness of this LV outflow tract septum. Now, if you see this hypertrophic cardiomyopathy on the right side of the slide, where you can see the septum is catenoid, it is bulging into the left ventricular outflow tract. So this is a chronic and progressive myocardial disease that is caused by dysfunction in the sarcomere. It perturbs heart structure and function with hallmark features of left ventricular hypertrophy, hypercontractility, and impaired relaxation and compliance. It is life challenging and the resulting in impaired functionality and the lower overall well-being. And by the time patients present to us, they have already thickness of heart muscle more than 15 millimeter. That is normal will be less than 13 millimeter, the thickness, and positive genetic test or family history of hypertrophic cardiomyopathy, which can be detected by detailed evaluation. And this causes mitral valve dysfunction so that the anterior mitral leaflet is pulled up into the LVOT during systole, and that causes further obstruction. So this is known as further obstruction of LVOT because of mitral valve systolic displacement of the anterior leaflet. Then cellular changes will happen into the structure and function of the papillary muscles as well and the left atrium as well. So in the echocardiogram, if we get a heart muscle LV IVS, interventricular septum, which is more than or equal to 15 millimeter, not 18 or 20, only 15 millimeter, then it is a positive genetic history of familial hypertrophic cardiomyopathy. And this diagnosis is based on the echocardiographic evaluation, which is normally we do mostly very commonly. And it just hypertrophic cardiomyopathy can cause serious complications even without LVOT obstruction also. So in the 6,000 patients when they have checked in the hypertrophic cardiomyopathy, 20 to 45% of the patients in across 3 trials have shown heart failure, and 33%, 4 to 33% had atrial fibrillation and arrhythmias, and 20 to 30% had non-sustained ventricular tachycardia, which can go to sustain and cause sudden death, like in the sports and all we see in the young children. And stroke can happen 4 to 9% in 2 prospective retrospective trials. So hypertrophic cardiomyopathy has been estimated to be associated with an all-cause mortality rate of 3 to 4 times, which is higher than that of the general population. Looking to this burden of the high mortality, we should be able to diagnose in the clinical practice. So what are the key pearls of the clinical diagnosis of hypertrophic cardiomyopathy, like dyspnea, exertional chest pain, lightheadedness, syncope, palpitations, family history, unexpected deaths, early heart attack, syncope, 3-generation family history recommended, consider genetic testing if positive family history, additional heart sounds, systolic murmurs, prominent apical impulse, brisk bifid carotid pulse, LVH repolarization changes in the ECG, P wave changes, abnormalities of Q waves, and the axis deviation and T wave inversions, and the comprehensive echo, including with provocative maneuvers like Valsalva maneuver and exercise, which can increase the LVOT obstruction in simple hypertrophic cardiomyopathy. So, ultimately, hypertrophic cardiomyopathy diagnosis is established on cardiac imaging. That is the key and the gold standard is 2020 AHA and ACC guidelines are given, and 2024 ESC guidelines has specifically given the diagnosis based on the unexplained left ventricular hypertrophy without any hypertension, without any aortic valve stenosis, without any much mitral regurgitation, 15 millimeter of IVS.
Ma'am, you have last
So,
2 minutes.
So this is the cross bridging. When we give mavacamten, what happens? This hypercontractility is reduced because it is a myosin inhibitor and it causes reduction in the hypercontractility, reduction in the bridging of the actin and myosin, and inhibition of myosin cross bridges formation has a direct impact on the underlying disease and reduction of the cross bridging. And this wonderful drug, mavacamten, directly addresses the pathophysiology of the hypertrophic cardiomyopathy. So all these trials have shown us clearly that how important it is to use mavacamten in correct doses, in correct specific Valsalva maneuver, 30 millimeter mercury, outflow tract obstruction, and long-term effect of the mavacamten. More than 5 years we have studied now, and the Velour HCM trial has also shown that very seriously sick patients also can be reversed. These are the RCTs which has improved so well and shown that how a person can be taken away from the surgical myomectomy or the balloon myomectomy conditions by just giving 5 milligram of mavacamten every day, daily, for 30 days. If you check, automatically you can see that LVOT gradient is completely disappearing and patient is coming back into the class 1 as compared to 2 to 3 class 1. So these are the ACCHA guidelines which has given the correct situation after the beta blocker and calcium channel blockers and disopyramide. If the patient is still having symptoms of class 2 to 3, then mavacamten is class 1A indication now. So that septal reduction therapy can be taken away. And surgical septal ablation or the balloon ablation can be taken away and patient can be easily treated with. This is the algorithm of the mavacamten, how we can use. In my clinical practice and in Hyderabad city, we have almost 300 patients. They are on mavacamten for HOCM, not simple hypertrophy, but HOCM, and they are doing wonderfully well. And most of the patients tolerate this drug very well. And it is a wonderful, I think, as you have told my, the caption of my presentation, that this can make a change in a patient's life without surgery, without heart transplant, and without any side effects of the surgery, like they go for the pacemaker implantation, so many things which can be prevented, and there is no side effects of this drug. I can tell you because we have been using extensively. This is the algorithm of the complete use, and this, I will go to the last slide now, and which shows that clearly, it shows that how we can maintain this complete clearance of the hypertrophic cardiomyopathy, just like surgical, better than surgical actually, I must say. Because in our practice, there is surgery is not done at all. In our, even the Velour HCM trial also, there was no surgery. They were taken away from the surgical group and from the balloon, means the septal reduction therapy group. So this drug is underutilized, underdiagnosed, and patients are not given correct treatment choices, which is a real hope for these patients. Thank you very, very much for giving me this opportunity, and I'm really thankful to the entire group. But your is cardiometabolic, but my topic is totally different for this latest new drug. Hopefully, hope creating drug. Thank you so much.
Thank you. Thank you so much, ma'am, for this wonderful insight on HOCM and what this drug is, a real discovery and a game changer in HOCM. Thank you, ma'am. So for your presence, we'll move on to our next speaker.
Our next speaker will be Dr. Satish Patanchetti. She is a well-known bariatric surgeon in Pune. So he will be discussing about mechanism of type 2 diabetes remission after the bariatric surgery beyond the weight loss. Over to you, Satish, sir. Hello.
Thank you very much. I have very
Yes, thank you.
Thank you, sir. Bye.
Satish, sir, are you there?
Dr. Satish?
Good evening, Satish, sir.
Is there?
Yes, sir, started. It started.
So Dr. Satish is just joining us in another minute or so.
So he'll be joining in a couple of minutes. So role of bariatric surgery is
Hello, am I audible now?
yeah, sir, you're audible. Over to you, sir.
Yes. Thank you, Dr. Parmeshwar and Dr. Reema Madam, for inviting me for this lecture. And I am truly obliged to give this lecture, lecture of bariatric surgery in a conference of obesity and diabetes. So I'll be speaking on diabetes remission, the mechanism of post-diabetes, post-metabolic surgery remission before weight loss. Next slide, please. So this presentation examines the evidence-based mechanisms by which metabolic surgery induces type 2 diabetes remission. Initially, we as surgeons used to do this surgery mostly for obesity, so it was known as bariatric surgery. But as we saw that diabetes goes off before the weight loss happens, so we are now calling this bariatric surgery as bariatric and metabolic surgery too. So all our societies also have transformed their names from only bariatric surgery to bariatric and metabolic surgeons. So we have seen that type 2 diabetes remission occurs within days of surgery, sometimes within the next day or within 2 to 3 days of surgery before significant weight loss happens. So there are 2 to 3 hypotheses which I would like to elaborate on as we go further in the lecture. First one is the hindgut hypothesis. Second is the foregut hypothesis. Third, calorie restriction, which is very common and which has to be done in most of the patients, but surgery offers durable and structural change. Then modern synthesis, reduction of hepatic and pancreatic fat is a key mediator of beta cell recovery, which is very important for insulin sensitivity, insulin production and insulin sensitivity. And what are the patient selection tools? Next slide, please. So there is a shift in paradigm from care to cure. As I told you, it was firstly before it was obesity before pre-1990, but as data, which he said that their glucose normalized before significant weight loss, and then this new era, right? Am I audible? Hello.
Your voice is breaking. I think
Hello. Am I audible now?
Yeah, you're audible now, sir.
Yes. Yeah. So beyond weight loss, we are leading to metabolic revolution. So what the data shows is that there are head trials comparing Roux-en-Y gastric bypass and sleeve gastrectomy against optical medical therapy, which reveal that there is almost around 76.8% of the patients there is type 2 diabetes remission post-surgery in obese patients, and it happens in days, not in months. So the time to glycemic normalization is in days and not in months, much before the weight loss happens. So it is there are much more benefic weight independent factors which offer diabetes remission. Next slide, please. So what is the anatomy of change? The main anatomy of change is we do a small gastric pouch, that we do a gastric calorie restriction. Second is bypass duodenum. Because we bypass the duodenum, there is foregut hypothesis. Then there is distal ileum, that is hindgut hypothesis, and there is roux limb, that is in which the bile salts are reabsorbed again in a much better way, and it causes much more better metabolic revolution, which we shall again discuss later. Next slide, please. So this is the Roux-en-Y gastric bypass, wherein we can see that we have done a small gastric pouch, and then this do a gastrojejunostomy here and a jejunojejunostomy here. So this is the esophagus. We swallow the food through the esophagus. It comes into this small pouch of the stomach, which is around 30 to 50 cc. So there is calorie restriction here. Then the food comes directly into the distal jejunum. Because the food comes directly into distal jejunum, there is early stimulation of L cells of ileum, which secrete the hormones, the incretins, which are very famous, that is GLP-1 and PYY. And also because we are bypassing the distal stomach, the duodenum and the proximal jejunum, there is foregut hypothesis wherein the insulino resistance factors which are secreted by this duodenum and the proximal jejunum are being bypassed, and then we get much more insulin sensitivity because of that, and that's why it helps in early metabolic dissolution of diabetes. Next, please. So the hindgut hypothesis is that there is rapid delivery of undigested nutrients to the distal ileum, which activates the L cells at an unprecedented scale. The GLP-1 activation, which happens with the help of, because of Mounjaro or because of Ozempic, it happens in hundreds, but here it happens in thousands and lakhs. So there is L cell activation, because of it there is surge in GLP-1 and PYY secretion, the primary hormonal drivers of remission. Then there is ileal brake effect. Because of ileal brake effect, there is slowing of gastric emptying, it suppresses appetite and it enhances beta cell insulin response. So this is the hindgut hypothesis. Because the food comes, undigested food comes directly into the distal jejunum and early into the ileum. Next slide, please. So what is the science of GLP-1 and PYY? GLP-1 stimulates insulin biosynthesis and inhibits glucagon, which is a dual anti-hyperglycemic agent. PYY reduces appetite and slows intestinal transit, reducing postprandial glucose excursions. Both these hormones are measurably elevated within days of RYGB preceding weight loss. So these are hormonal changes which help in diabetes remission rather than just because of weight loss. So there is improved glycemic control after hindgut hypothesis because this PYY, which leads to ileal brake, there is stimulation of distal ileum cells which leads GLP-1 and PYY. GLP-1 which acts on pancreas, GLP-1 acts on the brain, also on the prefrontal cortex, it suppresses appetite, and PYY acts on the ileal brake, which slows the gastric emptying. Next slide, please. So evidence review testing the hindgut theory. The challenge is if GLP-1 drives remission, there is a GLP-1 receptor known as exentin 9. So will blocking it should abolish surgical benefit? It does not. That's why totally depending on this hindgut hypothesis is not okay. So the findings are that GLP-1 receptor blockade partially but not fully reverses metabolic benefit, confirming it as a key but not the sole mediator of diabetes remission. Conclusion: hindgut stimulation is necessary but insufficient. There are additional mechanisms which must be considered and which must be researched also. Next slide. So we are going on from the hindgut to the foregut hypothesis. So the core premise in foregut hypothesis is that we are bypassing the duodenum and the proximal jejunum, which produce signals that promote insulin resistance. So bypassing them removes a diabetogenic driver. So there is anti-incretin theory proposed by Rubino and Maresco that proximal gut factors actively antagonize insulin secretion and their exclusion restores sensitivity. The mechanism is by removing the duodenal signal, allows the pancreatic beta cells to recover normal function independent of the calorie intake. Next slide, please. So there are K cells in the proximal gut, secrete a hormone known as GIP. So the K cells in the proximal gut secrete GIP, that is glucose-dependent insulinotropic peptide. Unlike GLP-1, GIP promotes bypassing the segment silences these signals permanently. That's why this promotion of fat storage is totally bypassed. So this RYGB, Roux-en-Y gastric bypass, restores this sensitivity and adipose and visceral fat storage is reduced. Hepatic insulin resistance in the context of obesity is reduced, and attenuation of beta cell responses over time happens. Next slide, please. So there is evidence that Rubino and Maresco did a duodenojejunal bypass, that they bypass the duodenum and jejunum in non-obese diabetic rats, in which there is no gastric restriction, that is no caloric reduction, in which they saw that there is significant glycemic improvement despite unchanged body weight. The rats were eating proper food, proper calories, but they had significant glycemic improvement despite unchanged body weight. So the implication was that intestinal bypass itself, not calorie restriction, drives glucose homeostasis changes. So this landmark study provided the first direct evidence that foregut exclusion independently alters glucose regulation, a paradigm shifting finding done by Rubino and Maresco. Next slide, please. So debate is whether foregut versus hindgut. So both these hypotheses help together, in which the distal stimulation boosts beneficial hormones, proximal estrogen silences diabetogenic signals, and both act simultaneously in Roux-en-Y gastric bypass and help in type 2 diabetes remission. Next slide, please. The current era rule of calorie restriction, everyone knows. Certainly, yes, very low calorie diets produce rapid glycemic improvement, but it is not feasible for all patients. But it reduces hepatic fat, decreases pancreatic stress, and improves beta cell production and improves insulin production. Next slide, please. So the stages are that calorie restriction. How the modern synthesis happens is that the calorie restriction reduces hepatic fat within days. In stage 2, lower liver fat decreases hepatic glucose output. Stage 3, pancreatic fat mobilization restores beta cell function. And stage 4, improved peripheral insulin sensitivity considers remission. Next slide.
So we are running out of time. 2 minutes.
Yeah. So beyond gut hormones, there are microbiome and bile acids. There is microbiome shift. RYGB induces profound durable flora, which alters energy harvest and inflammation. Bile salts, there is TGR5 receptors and FGF19 pathway, which also help in diabetes remission, independent of GLP-1 and independent of weight loss mechanisms also. Next slide, please. So in summary of discoveries, the hindgut stimulation, which is GLP-1 and PYY surge from L cells, foregut exclusion, that is GIP suppression, anti-incretin silencing, the hepatic fat clearance, the bile acid and FGF19 enhanced glucose regulation model, and microbiome remodeling, reduce formulation. All these factors, which are weight independent factors, helps in type 2 diabetes remission even before weight loss happens. This is all because of gastric bypass or bariatric surgery, which we do. Next slide. So in summary, beyond the skin, clinical evidence confirms that Roux-en-Y gastric bypass induces type 2 diabetes remission through a rapid neuroendocrine shift, often within days of surgery. And there's an integrated foregut as well as hindgut. And there's an orchestrated health of hormonal surge, bile acid signaling, and gut microbiota remodeling, which helps in type 2 diabetes remission. And it's a new paradigm. It's metabolic surgery is just not weight reduction. It is a sophisticated biological rewiring body's energy homeostasis, reclaiming from chronic metabolic disease. Thank you.
For giving us some insight about how metabolic surgery can help us to give the remission in diabetes, early and long-term remission. So I have one question for you. How do you see sleeve and endoscopic sleeve as a metabolic surgery?
So sleeve and endoscopic sleeve acts only on hindgut hypothesis and not on foregut hypothesis. So it helps in type 2 diabetes remission, but with not all the factors which we discussed now, such as hindgut, foregut, bile acid modeling, microbiota rechange. It doesn't help in that much. So sleeve and endoscopic sleeve especially cannot be termed as full metabolic surgeries. If you want a complete metabolic surgery, you need a gastric bypass. So a Roux-en-Y gastric bypass or one anastomosis gastric bypass are much better surgeries than just sleeve gastrectomy, endoscopic sleeve gastrectomy for metabolic reversal of diabetes.
Thank you, sir. Thank you so much for your time.
Thanks.
And any question from audience? I think there's no question. Thank you, sir. Thank you so much for your time.
So moving on to our next session, our speaker would be Dr. Suhas Khere. He would be talking to us about the inhaled insulin and the latest once weekly dosing of the insulin. Over to you, Dr. Suhas Khere.
Good evening, everyone. I want to share my slides. Can you just allow me?
Yes, yes, sir. Yes, sir.
Yeah, just a minute. Hope I am audible and slides visible.
Absolutely, clearly.
Yeah, so good evening, everyone. At the outset, I would like to thank organizing committee for giving me this opportunity. And after listening to all these lectures, and recently I listened about bariatric surgery remission, diabetes remission with bariatric surgery, I am moving towards the inhaled insulin, which is Apreza, So we are in the era of diabetes and obesity. There are many new drugs coming in the last few decades. We have seen how the landscape of diabetes management changing, and how the convenient insulin is coming, right from the very old coming to the rapid acting insulins. We have very, very long acting insulins. Hello. So we are moving to, and we have now the very, very rapid acting insulins. So what I'm going to talk about, the first we'll see about how the emergence of technosphere insulin, that is inhaled insulin, came. What is the clinical pharmacology? We'll see about some evidences of this insulin, and we'll see what are the things to remember before initiating the aphasia. So how this insulin is actually like. This is a non-invasive method of delivering insulin and directly into the lungs, which bypasses the need of injection. And owing to the larger surface area of the lungs, insulin is absorbed faster, and it controls your postprandial spikes. So how the history looks like? So initially the concept of inhaled insulin investigated in the Germany, and that usually they tried in 1971 into the rabbits also. In 2006, the US FDA approved Exuvera, which was by Pfizer, but it was immediately withdrawn in 2007. In 2014, this phrase approved by Mankind Corporation, and in the last 2024, so last year, 2 years back, the Cipla received the approval for the distribution and marketing of Afrezza in India. So the technosphere insulin consists of regular human insulin absorbed on the fumarate diketopiperazine particles. Small discrete fizzle-shaped breath-activated generation 2 inhaler with single-use TSI pre-filled cartridges for oral inhalation. And indication is to improve the glycemic control in diabetes patients with type 2 diabetes. So how it actually works? So at pH less than 6, this insulin absorbed onto the carrier microparticles of FDKP and filled into the pre-meter plastic cartridges. And when inhaled, they directly go to the alveoli into the deep lungs. And at this pH, this insulin rapidly reaches to the systemic circulation, and within 15 minutes, we get the maximum concentration. So what we avoid the first class metabolism because of this structure. Directly we are inhaling. Also, it is very rapid acting insulin and rapid ultra onset acting insulin. So that's how the dosing of insulin looks. You can see there are different colors for 4 unit, 8 unit, and 12 units. So these are the 3 color coded things, and we administered by oral inhalation, and we need to give, so it acts as a prandial insulin, so we need to do just before the meal. Definitely it will not counter or act as a basal insulin. We need some basal, will act as a prandial insulin. Recommended, you can start as similar to your subcut insulin. So suppose if you're on 8 units, you need to start at 8 units of Afrezza. If you're on 10 units, you need to give the same 10 units, right? So how is the impact of delivering insulin via lungs? You can see the endogenous insulin in the healthy humans, time to reach the measurable effect is 10 minutes, and with TSI it is almost 12 units, and time to peak effect is 45 in the endogenous insulin, and TSI also almost same. So you can see almost it closely resembles your endogenous insulin. We'll go through quickly some pivotal clinical studies. So Afrezza in type 2 diabetes, we have this study which is randomized control trial, 24 weeks. One group they have TSI with OADs, and second group they have TS placebo with the OADs, and this 12-week study is, so total 24-week study. And what they compared, so this was the inclusion exclusion criteria. They took patient insulin naive with diabetes more than 12 months, HbA1c 7.5 to 10. And one important thing is that FeV1 should be more than 70%. Patient should be non-smoker for less preceding 6 months. So what they looked at 24 weeks change in HbA1c, and they also looked at the safety outcomes like hypoglycemia. You can see the results of Affinity 2 trial. Difference in HbA1c was minus 0.4%, which was significant, and glycemic improvement in the TSI group was evident by just 2 weeks. You can see the separation of these two groups very early, right? So to compare these two groups, in the placebo group and TSI group, there are more than 2 times patient reached A1C target less than 7%, and 4 times patient their target HbA1c is less than 6.5%. So this is the similar results. So this is the phase 3 study, Afrezza phase 3. What they have looked at 24 weeks, again, once again, one group they compared with the TSI with the OADs, and second group with the placebo with the OADs. This is 24-week study, and usual care in given in both the arms. Here also the similar inclusion exclusion criteria you can look, and after 12 weeks they compared the results. And here also you can see the significant A1C reduction at 12 weeks in the Technosphere insulin group, that is Afrezza group. Hypoglycemia definitely we reported little more in the Technosphere group because it's a rapid acting insulin as compared to the placebo. But what is more important for all of us, that there is no difference between the FEV1 observed between these two arms. You can see in this graph, right? To summarize about Afrezza, it added to OAD is an effective option for inadequately controlled type 2 diabetes, and the findings are consistent with the earlier studies and may support the timely initiation of insulin. What is more important about the where not to use, what are the how you use in a special population? So we don't have hepatic data, we don't have renal data. Pregnancy, lactation not allowed at present. Geriatrics, we don't have much data after 65 years. Pediatrics, it is not yet approved, right, below 18 years. So how about safety? So we are always worried about this inhaled insulin, about the how safe they are, because there are some side effects. Most common is cough, throat pain, headache. So these are commonly you can see between the placebo and TSI. There is a little bit difference. Cough is common in the TSI group. You can see 25% as compared to the 19%. And this is what is more important. This cough is very high, but it is at the beginning. The incidence you can see 26% as compared to the placebo 5%. But usually the cough is dry, mild. Within 10 minutes of inhalation, it comes. And after when we use this Afrezza for a little long time, the cough subsides slowly. Change in FEV1 you can see from the baseline. We need to monitor the FEV1 mostly when patient we start on the Afrezza. What about lung malignancy? There are 2 case recorded, but these patients were heavy smokers, so there is no definite link of Afrezza with the lung cancer as well. And American ADA Association 2026 has put, they have positioned the inhaled insulin in patients when their patient have definitely required a prandial insulin in a convenient way, and we can use in this patient. Definitely FEV1 need to be monitored prior to starting these insulins. Whom to exclude? This is also very important. Chronic lung disease patients such as asthma, COPD, we should not give during the episodes of hypoglycemia. Patient, if it is hypersensitive, FEV1 less than 70% of the predictive value at the beginning, don't start. And smokers, on also those smokers who have left smoking in last 6 months, they should be avoided. So this is very important. We should not start in this group of patients. And before initiating Afrezza, it is necessary to perform detailed medical history, physical examination, FEV1 to identify potential lung problems. And also we need to do FEV1 at baseline after first 6 months of therapy, and again thereafter annually, even in the absence of pulmonary symptoms. And if patient suppose FEV1 reduces more than 20% from the baseline, if patient is on Afrezza after maybe 3 months, 6 months, need to discontinue. You cannot continue if FEV1 is dropping by more than 20%. So I am quickly going through the next thing, that is FC-TORA. This is a once weekly insulin. As I already told, we are on a quest of developing newer and newer insulin, which is very long-acting insulin. So FC-TORA.
Sir, your voice is cracking a lot in between.
Okay.
Now it's much clearer, I suppose.
Yeah. So I think there are just 2-3 slides. I will just wind up. So FC-TORA insulin is actually a once a weekly insulin, and we all know recently the second insulin, that is Icodec, recently approved in India. for the basal insulin. So once we can give a weekly insulin. Epsitora is not yet approved in India. It is also weekly insulin. This is in the phase 2, phase 3 trials at the moment. But what it shows that, so how actually this insulin will see. So mechanism is a once a weekly basal insulin. It has one fusion protein that combines a single chain insulin variant with the IgG2 Fc domain, and it is designed to lower blood sugar in type 2 diabetes, provided stable glucose control. Definitely, because this is a very long acting insulin, almost it will act for 7 days, and we can replace for our older basal insulin like your glargine insulin or maybe your degludec insulin. So this is a good alternative. This is still in the pipeline. It is will approve in a maybe next recent few maybe months or years. We need some approvals. So there are series of 5 phase 3 clinical trials called as Queen development program actually happened with this Epsitora. So Queen 2 and Queen 5 trials, they took the patient who are insulin naive patients with type 2 diabetes and also with type 1 diabetes, and they compared with the degludec, and with both trials what Epsitora was found to be non-inferior. So these trials are basically non-inferiority trial. They are not a superiority trial, and they found that the lowering of the glycated hemoglobin levels approximately similar between these two groups at 52 weeks, and also the hypoglycemia risk is almost similar. So to conclude, what I want to convey today is that Advil is the only inhaled insulin approved to use in diabetes patients. We have some patients are very happy with the injection. I don't want injection, and this kind of patient we can use this kind of insulin, rapid acting mealtime insulin along with the compact inhaler device. It is oral inhalation of the regular human insulin for prandial glycemic management. It is found to be safe and effective in clinical trials over 3,000 patients, often proves the mealtime glucose control and very fast acting, as I said. So that's why within 12 minutes, we get a prompt reduction in the blood beginning. We need to be a little careful if patient is having all these contraindication. We need to screen at the moment at first, and it is approved by the Indian regulators for adult patients with diabetes. What about Epsitora? It is a once a weekly insulin, very long acting basal insulin, found safe and effective in clinical trials with Queen program. Will reduce the injection number right from 365 to just 52. Imagine, so just 52 injection in a year, and Epsitora provide a very stable glucose control over a week without causing risk of hypoglycemia. With that, I will stop here. Thank you.
Thank you, sir. Thank you for telling us about these new insulin techniques which are available now in the science to control patients of sugar with type 1 and type 2 diabetes. So I would like to know, how should clinicians adjust dosing for high fat or prolonged meals with Afrezza? Dr. Suhas, are you
Am
there?
I audible?
Yes, sir. Now you are. Yeah.
I missed your question. Can you just repeat, please? Sorry.
So, as clinicians, how should we adjust dosing for high fat or prolonged meals, especially in case of inhaled insulin?
Yeah, so I think this could be a maybe a little challenge, because these insulins, they act very fast. They just goes to the alveoli and they will immediately act. So maybe the dose you can increase a little bit, but I may not be very comfortable maybe when using this kind of insulin in this patient, because if I increase the dose, they may go into the hypoglycemia as well, because they're very fast acting. And we can compare this insulin with like your very rapid acting aspart or Fias like insulin, right? But what happens when I increase the dose, the sugar may crash a little bit. But so this kind of patient, I may not feel I'm not very comfortable if patient is a very high fat meal.
Okay. So, and what would be the common mistakes what a clinician can make while initiating a patient on Afrezza?
See, most important mistake I would say that about the screening. Maybe you need to screen for your FE1 and all these things need to be done at the beginning, because we cannot use this insulin in this kind of patients. So some patient practical experience I will tell you that few patients have started, but they will not, maybe its effect may not be very consistent in few patients. Maybe how they take technique is very important, how they inhale this insulin. Second thing, they may feel this throat cough. This side effect we need to take care, and I always tell that you need to, or previously discussed, like FE1 we need to measure maybe at the beginning and maybe every interval. So these things I think we need to remember.
Okay.
And
So
also one more thing, just to add, that patient should be on a stable doses. We cannot use in this when patient is rapidly changing, or maybe the variable patient is diabetes is little labile. I don't think it will act very in a sound way.
Okay. And sir, what about in type 1 in young children and all? We can
See, it is not yet approved in a young patient, type 1.
Okay.
It is approved after 18 years in type 1.
All right. So can these inhaled insulin can complement hybrid closed loop or automated insulin delivery systems, or does its pharmacokinetic profile can create challenges?
It definitely it will complement, I would say, because see, closed loop systems, we can give the basal in that, and maybe we can, but how the sensor will maybe, so the closed loop system and the maybe this system, they may not sense this mealtime insulin. So this mealtime we have to give when, so we need to see when this is going on. It may complement in, but we need to educate the patient that way, that if you are taking a basal in that, so you can take just the prandial meals with the Afrezza, and so we can make it, but definitely need some maybe technical things.
Okay. And sir, one last question for you.
Yeah.
How should Afrezza dosing be titrated using CGM or SMBG?
Yeah, I think that can be done if you are using a CGM for a patient, and we know that some basal insulin we are already giving, and Afrezza we are giving by the inhalation, and we can see the prandial spikes, how the patient prandial sugars are behaving postprandial, maybe after 1.5 hour or 2 hour, and you can then change the doses. We can give a supplemental dose as well, like we are giving you a subcutaneous insulin. Patient PP sugar is a little high, we may give a supplemental insulin. Likewise, we can give these insulins also, because they are not very long acting, so we can maybe give in multiple times also for your prandial insulins.
Right, sir. Right. Okay. Thank you, sir, for your insights into this. So, anyone from the online people would like to ask any questions from the participants and the joinees? Okay. I don't think so we have any more questions. Thank you, Dr. Suhas Kere, sir, for joining us.
Thank you very much, Kritika, and thank you, Dr. Parmeshwar. Thank you.
Thank you.
Sir, thank you.
So let's move on to our next session by Dr. Sujit Sawadkar. He's the cardiologist, and he would be talking to us and giving his wonderful knowledge on obesity and hypertension. Welcome, sir. Over to you.
Okay. Thank you, Dr. Kritika. Thank you, Dr. Parmeshwar. And I thank Noble team for organizing this wonderful session on obesity and probably all the complications related to obesity. Now we can bring down to the single factor, that is metabolic disorder and this obesity. So I'll start straightforward.
Yes, sir. You can. Go ahead.
Okay. So I have been given the task to discuss about obesity and hypertension. So before beginning, I'll just want to share my slides. I think someone has to change the settings.
We'll do.
Yeah. So, okay.
Yes, sir. You can do. You can.
My slides are visible now?
Yeah.
Fine. So just a short disclaimer that I have used the new technology, that is ChatGPT, Notebook, LLM and everything. But as I was going through that, just a small thought came in my mind that we are using all this technology to improvise the humanity, right? And we are developing all these newer medicines, newer technology, now the metabolic syndrome and all those things are coming in. But just a quick thought that all this technology are making us sedentary. We are increasing sitting and increasing our weight, and now we are finding medicines to reduce that weight. Okay, so this is a kind of a big irony the humanity is going through. So let's move on to the obesity topic. And we all know that there are hundreds of deleterious consequences. And now today's session is hypertension. You all must have wondered that patients nowadays, when they are coming to OPD and they are saying my BP is controlled, but when we see that their BP is 140 by 85 or 135 by 85, and we label them as hypertensive, they are not ready to accept this. So probably the recent guidelines have made this hypertension as 130 over 80 as the upper limit. So with keeping that in mind, we'll go through what this obesity is responsible for this hypertension. So if we see the epidemiology and many studies, they have time and on showed that the almost 65% in women and 78% in men who are having hypertension, though the excess body fat is responsible for that. And if we go by some more data, then almost a mere 5% increase in weight leads to 20 to 30% spike in the hypertension incidence. That's a very big thing. It's not only about the hypertension, it is the entire cardiovascular system which is at risk because of the increased weight. And if we look at the female population also, then almost a 14-year prospective study which has shown that those women who have higher BMI, they are almost 5 times more incidence of hypertension. Plus, if we look at the top edge study, just a minute. Sorry, is my slide visible?
Yes, sir, it is visible.
Probably somehow my... Okay, fine. Yeah, got it.
Yeah.
So almost 65% risk reduction is there when we reduce the weight. So there is enough evidence that hypertension itself is responsible for the increase in the... is someone changing the slides from somewhere? I'm not able to change it from here.
No, sir.
Sorry, I don't know what is happening.
Try again, sir. One
I
second.
have to stop sharing and then I'll see.
We will look from here, sir.
Okay, got it. So age-old standard baseline thing is that we usually only calculate BMI, but there is enough evidence that even the visceral and retroperitoneal fat, which is also responsible. Much has been talked about waist circumference and waist hip ratio. I'll not go into detail, but we have to consider these factors when we are actually dealing with obesity and hypertension and CV risk. So we will have a short look on pathology and one factor each. So excess fat, that is visceral retroperitoneal fat, is responsible for a cascade of reaction which is happening in the entire system. And obviously there is activation of sympathetic nervous system, then RAS system is also stimulated. At the crux of the center, there is hyperinsulinemia and insulin resistance, which is very much the topic of discussion. Plus, there is hyperleptinemia. This is a cytokine which causes all the problems. And there is a very unique concept which is being discussed nowadays, that there is a mechanical and structural renal changes. Actually, the fat compressing on the kidneys, that is also responsible for the increase in the blood pressure. So we'll go, this is a very crowded slide, but keeping simply in our mind that visceral obesity leads to multiple pronged increase in the problems which causes ultimately the hypertension. So I'll not go much into the details, but ultimately that hypertension leading to insulin resistance, hyperinsulinemia, glucose intolerance, dyslipidemia, and ultimately lipotoxicity leading to CV complications. This ultimately leads to diabetic and obesity cardiomyopathy, and patient obviously with hypertension goes into morbidity and mortality related to CV complication. So if we look at a cascade of cycle, and the entire thing is like started, or the engine is started from the excess fat, and it causes kidney issue, like mechanical compression of kidney and renal medulla, that ultimately causes decreased sodium delivery to the macula densa, and ultimately this leads to feedback activation of RAS and also the sympathetic nervous system. ultimately BP increases. This vicious cycle causes the damage to the nephrons, and ultimately the same cycle keeps on repeating with increase in the blood pressure. So sympathetic nervous system overactivation and RAS system go hand in hand, and they ultimately leads to the high blood pressure. Along with that, if we see how the renal injury itself is problematic, so I've touched it in a gist, but again I like to give some focus here, because this is a very unique thing, that the fat around the kidney, the intra-abdominal fat that compresses the kidney, the flow, arterial flow, the anterior arteriolar flow decreases, and that the macula densa sense that there is a decreased sodium delivery to the distal nephron, and that causes feedback activation of RAS, and that ultimately leads to activation of sympathetic nervous system, and this feedback loop keep on going on. The BP increases, and ultimately that overburdened macula densa is ultimately goes into injury, and the nephron injury sets in. That further leads to the increase in the blood pressure. So this is a very unique concept related to the fat around the kidney. And if we see, then that mechanical compression is kind of an initiator, and probably the RAS system, SNS, macula densa, they become the accelerator, and ultimately the BP keeps on increasing, and this loop continues endlessly, and there is no decrease in the blood pressure. So ultimately this is kind of a mechanism for resistant hypertension. So what also contributes to this is nothing but leptin and insulin itself. So insulin resistance and hyperinsulinemia, which is at the center stage of this obesity, plus the leptin resistance also, which causes the resistant hypertension, and many of these patients are very difficult to control with multiple antihypertensives. So what happens exactly? There is increase in the aldosterone production, renal sodium absorption. So same thing, same cascade goes on. But now the leptin is the main confounding problem. Plus, there is something called as leptin paradox. So when you this must have been discussed many times during the discussion, because this is more of a topic of a obesity rather than a cardiac. But I just want to highlight here what leptin plays as a role in increasing the blood pressure. So what is happening? Leptin also causes some damage or rather than the appetite center in the hypothalamus is suppressed, and that causes the reduction of early satiety. That causes the increased hunger, and probably that's why the patient keep on eating, and that's why the patient's weight goes on increasing, and this cycle goes on increasing. The leptin secretion increases, ultimately sympathetic activation RAS comes into the play, and patient's blood pressure increases. The same way hyperinsulinemia also cause the increased sympathetic activity, increased heart rate, sodium reabsorption is increased, pressure natriuresis is decreased, and ultimately volume overload leads to hypertension. So if you look at different mechanisms, how the insulin causes damage, it is by endothelial damage also, where nitric oxide production is decreased, and there is endothelin release plus vascular vasoconstriction happens. If we go by the same analogy where we can predict that whether the patient will develop diabetes or not, we can use the same HOMA-IR formula for knowing whether the patient will ultimately land up in hypertension and cardiovascular morbidity. So same thing which has been discussed here, leptin and insulin both go hand in hand, and ultimately they cause the central nervous system, sympathetic nervous system activation, RAS activation, and ultimately endothelial injury also sets in, and patient goes into a hypertensive state, and ultimately leading to CV, morbidity, mortality. So what is important here, that we have to understand that it is a kind of a dual pathway which definitely needs therapeutic intervention in the form of whatever the medicines which have been developed in recent years. So all is been talking about the same mechanism, and the importance is given to this mechanism also, besides the kidney and RAS and sympathetic nervous system. So we'll go one by one on how can we treat this obesity related hypertension. The primary goal should be obviously the blood pressure control, but now looking at this concept, the primary goal should be weight loss. So what we can see from many studies that 1 mm reduction can be reported with 1 kg of weight loss. But over a period of suppose 1 year, if you are losing 10 kg of weight loss, the blood pressure on an average reduction will be 6 millimeters of mercury. So what is our aim? That to reduce the weight, the lifestyle changes has to be there. Adjuvant pharmacotherapy has to be there, and there is a big role of metabolic surgery in morbidly obese patients where hypertension and CV risk is very high. So we all know that lifestyle modification requires calorie restriction, increased physical activity, behavioral modification. But here the issue is that there are a lot of dropouts. Patients are not motivated. There is a difficulty in achieving the goal, weight goal, and very difficult to maintain that long-term weight loss also. And obviously the counter regulatory hormones, leptin and insulin interplay also is at the background, which causes uh, less reduction in the weight. So what we have now, we have pharmacological management where even the society, the guideline, endocrine society and ACCHA guidelines also are recommended that the weight loss medications has to be started in those who have BMI of more than 30 kg meter square, and those who are having more than 27 BMI but with obesity related diseases like hypertension, type 2 disease and dyslipidemia, and specifically OSA patients. So our aim to treat with medicines is to treat the hypertension also and treat the obesity also. So what we have here in the treatment of hypertension, obviously RAS system is at the center stage. So we have to include ACE inhibitors, ARB, and probably ARNI also in the treatment of hypertension. It improves the insulin sensitivity and it is ultimately nephroprotective in both hypertensive and diabetic patients. Then MRA is also very important in reducing and altering the mechanism by which the obesity causes hypertension. Beta blockers, I will say the older generation of beta blockers were prone for weight gain and insulin resistance, but nowadays we have specific cardioselective drugs like carvedilol and nebulol, which can be given and which may have a neutral effect on weight, but probably have a very beneficial effect when some cardiovascular conditions are there, like heart failure and those who are post-MI patients with reduced ejection fraction. Then CCBs usually have a neutral effect on weight, but they will definitely have a effect on reducing the blood pressure when we don't have any other medicines to add on to, and that can be added as an adjunct. Then thiazide diuretics has to be avoided as far as possible because they have some adverse effect on dyslipidemia and insulin sensitivity. So what we have in armamentarium is ACE inhibitors, ARBs, MRA, beta blockers, and probably CCBs also. Considering the anti-obesity medicines, much has been talked about the medicines, but I will just highlight what these drugs are effective in reducing the blood pressure, because today's topic is blood pressure control by controlling the obesity. So we can see that almost the benefit which can be achieved is with tirzepatide and semaglutide, where almost the BP reduction can be seen up to the level of 7 to 10 millimeters of mercury. The other drugs have also shown some benefit, but a few drugs like orlistat or probably bupropion or some other drugs which were older generation of medicines, they have been neutral to the reduction in the blood pressure by reducing the weight. So if I have to put the ranking of what obesity medicines can do for the blood pressure reduction, then I'll put tirzepatide as the first one. Then semaglutide, probably liraglutide will also reduce some blood, but the others are of not much benefit in reducing the blood pressure. This is the mechanism by which the blood pressure reduction can be achieved. And then if I see the we have to give patients medicines as per the clinical scenario. So what my take on this would be, like, if the patient is obese and hypertensive, then probably the greatest blood pressure reduction can be achieved with tirzepatide. If the obesity is there, and there is a established atherosclerotic vascular disease, like patient have stroke or patient have some MI in the previously, but without any diabetes, then semaglutide will be the better choice. Those patients with obesity, type 2 diabetes plus high CV risk, both the drugs can be used. Heart failure, particularly with obesity, then the first choice should be tirzepatide. And those with CKD obesity, both the drugs can be used. So probably this is a small gist how we can choose the medicine as per the clinical situation. Then some emergent drugs are there, and which are showing a very great promise in reducing the blood pressure also, and also there are some cardiovascular outcome trials are going on. So we'll look into that key what this drug can do in future about the hypertension and obesity plus reducing the cardiovascular risk. Coming to the bariatric surgery, I feel there is not much of a data available from the India ki what kind of surgery is done. So US data usually shows that sleeve gastrectomy, RYGB are the primary types of surgeries which are done. Much has been talked, and Dr. Parmeshwar is there, who is an expert in bariatric surgery. But I'll take a point here that how this bariatric surgery help improve the hypertension. So my point of telling all this is just to highlight how this bariatric surgery is helping in reducing the hypertension. So if we go by the type of surgery, then probably the very good efficacy of weight loss is with this BPD and DS. But these are very technically challenging surgeries as far as I can say. But probably the SG and RYGB, which are done most commonly, they also have a very good blood pressure, obesity reduction. And ultimately this obesity reduction also causes the overwhelming reduction in the blood pressure. So as for there are many statistical studies which have shown that almost up to the 63% reduction have been found in the improvement in hypertension, and this can be a sustained over 2 to 5 years. So we can conclude from that bariatric surgery does make a difference in reducing the blood pressure. But there was a little bit deviated data from the Swedish obese subject study, where over a period of probably 20-25 years, band-aid gastroplasty has not shown any good result in terms of reducing the blood pressure. But probably that was the older technique of doing the bariatric surgery. But nowadays the common type like RYGB or SG, which has been used, that had shown a promising result over a period of 2 to 10 years. But as the time passes, the patient's long-term stabilization of blood pressure is little bit questionable. But probably this may be the effect of the study bias, which was because the patients which were included, they were not actually studied for the reduction in blood pressure. This is kind of a subgroup analysis. So we cannot actually confer from this that whether the bariatric surgery has actually helped in reducing the BP, but we can definitely see the difference as the other aspects of CV morbidity, mortality are also improving by doing the bariatric surgery. So comparing the surgery group versus medical therapy, so probably a single center study has shown that surgery is more effective than the pharmacotherapy, but probably this data is also little bit older, where the newer drugs have not been head-on used with the surgery group. So what we can get from this is that as pharmacotherapy is evolving, and as bariatric surgery also shows hypertension we may put pharmacotherapy and bariatric surgery like a combined therapy for these patients to reduce the blood pressure and to help in improving the CV risk. So what my take on this will be that probably the bariatric surgery is not a single symptom mechanical treatment. It is kind of a holistic treatment, and nowadays the drugs are also proving to be beneficial in that. And now we come to the final part where I think everyone most aware, and that is the conclusion. So what I want to tell here is that obviously everyone knows that obesity is a major driver for hypertension by various mechanisms. Weight loss is the cornerstone of the management. Obesity-related hypertension is frequently resistant to conventional antihypertensive therapy unless and until you reduce the weight. So that's why where the pharmacotherapy comes in the picture, and which is showing very great promise in reducing the weight as well as hypertension and other CV morbidities. Metabolic surgery is the most effective long-term treatment for severe obesity, where hypertension remission and cardiovascular risk reduction is concerned. And metabolic surgery should be considered for selected patients with severe and refractory obesity-related hypertension plus CV risk. Thank you. Thank you. Thank you for your patient listening.
Thank you, sir. Thank you. It was a very good presentation, sir. Many things were cleared, the pharmacotherapy and the bariatric surgery and everything. I would like to ask, so are there any concerns regarding heart rate elevation with GLP-1 receptor agonist in hypertensive patients?
Yeah, there have been like reports and there has been studies going on, but usually when the antihypertensives are given, I will prefer the therapy should be like multimodality. When we are giving the antihypertensives nowadays, it has been said that you give multiple molecules which are acting at different level. So it is not only that single drug which we can prescribe; we can use 2-3 medicines, and probably that simple sinus tachycardia can be taken care with beta blockers also, which ultimately the newer beta blockers or cardioselective beta blockers. So there should not be an issue as such for the tachycardia per se.
Okay. Also, sir, if you could change one aspect of a current obesity hypertension management, what would that be?
Acha, okay, this is a big question to answer in a short thing. See, obviously, as I started my presentation with, the first thing should be that we should not allow the obesity to develop. I think that should be the first challenge, that obesity reduction or obesity prevention should be from the childhood, and not that once you become obese and then we try and do something for that. I think probably that should be the current challenge for everyone, not only the doctors or not only the patients. It should be from each and everyone in the family. Probably this obesity reduction starts right from the childhood, or probably when we start weaning the kids, right? I think that should be the answer.
Okay, yeah. Anything you would like to ask? Okay. Thank you. Thank you so much, sir.
Thank you so much. Thank you for giving me the opportunity. Thank you so much.
Yes. So moving on to our last presentation, it would be by Dr. P.C. Manoria on evolving landscape of obesity, a paradigm shift in CKLM care. Thank you, sir. Over to you.
waist circumference, waist to hip ratio, or waist to height described, or at least two measurements of body size, regardless of BMI, or the facility for estimating body weight to the next can do that. Or your BMI is very high, more than 40, this is diagnostic of obesity. But this definition does not take into consideration the symptomatic limitation of activities due to obesity, and the obesity associated with comorbid disease. Therefore, there has been a revised definition of obesity in Asian Indian livings in India 2025, Dr. Anup Mishra, which says stage 1 obesity is your BMI more than 23, and the other anthropometric measurements are optional, but there are no symptoms of limitation of physical activity in day-to-day work, and there's no obesity-related comorbid disease. Where stage 2 is your BMI is more than 23 plus one of the anthropometric measurements which are mentioned on the screen, and the patient has obesity-associated limitation in its activities and also obesity-related comorbid conditions. Now, during the last couple of years, there has been a drug revolution in obesity. We have single GLP-1 agonist semaglutide, which has shown reduction in weight by 15 to 17% in the STEP trial. It has also been tried in non-diabetic obesity with pre-existing cardiovascular disease, where it showed a 20% reduction in the primary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke. And the benefit, as you can see, starts very early before any significant weight loss occurs, clearly indicating these effects are independent of weight loss. And the criteria used for this trial was BMI more than 30 or BMI 27 or greater with at least one of the weight-related comorbid conditions. Then we have dual agonist tirzepatide, which is GIP-GLP-1 combination, and this was tried in the SURPASS and the SURMOUNT trial. And the SURPASS trial showed reduction in weight of 9.5 to 13 kg, good HbA1c reduction, and the SURMOUNT one showed weight reduction to the tune of 22.5%. And we have caclesema, which is a combo of caclitide and a fixed dose of sema 2.4, and has shown reduction in weight of 17% has been tried in the Rio 1, 2, 3 trials. Then we have triple agonist retatrutide, which is a phase 2 showing 24.2% reduction in weight, and the phase 3 Trump trial has shown reduction in weight to the tune of 28.3% in the 12 milligram dose, just near the bariatric surgery. So anti-obesity medications are now competing with bariatric surgery. Any amount of weight loss is beneficial. If you decrease weight by 5%, it starts impacting insulin sensitivity and beta cell function. If you decrease weight by 10 to 12%, the magnitude of benefit is greater, the spectrum of benefit is wider, it starts impacting gene expression in adipose tissue. If the benefit is more than 15%, there's greater benefit, it starts inflammatory markers too. Now, this shows the benefit of weight reduction, and if your weight reduction is more than 15%, you can see type 2 diabetes may undergo remission, cardiovascular mortality decreases, health level growth. Diabetes remission is possible, but reversal is there. Diabetes remission means that the HbA1c below 6.5% without any diabetes medication for at least 3 months. These anti-obesity, if the patient is obese, he gets deposition of fat in the liver, gets massive fat deposits in pancreas, and interferes with insulin secretion, which you get diabetes. But if you lose weight, the fat from the liver decreases, fat from the pancreas decreases, and insulin secretion improves, and diabetes may undergo remission. These are the predictors of remission in diabetes: age less than 15 years, and drug-naive patients, shorter duration of type 2 diabetes less than 6 years, lower baseline HbA1c less than 7%, not requiring insulin, BMI more than 25, weight loss more than 10%, and no major comorbidity. Several trials have been conducted for diabetes remission. One of the famous trials is the DIRECT trial, which utilized low-calorie total diet, and you can see there was a 46% remission at 12 months and 36% sustained remission even at the end of 2 years. How long anti-obesity medication should be taken is a very interesting question. And now we have de-escalation protocol, which means you start with an injectable GLP-1 or a combo that is tirzepatide for 1 to 2 years or more. And then you can continue on a low dose of these agents. The option B is you can switch to an oral semaglutide. This orforglipron is not yet available in India. And the third option is if you have very intensive lifestyle modification, you can stop these drugs and continue with lifestyle modification. Despite these innovative molecules, research continues unabated in anti-obesity medication, and there are several drugs in the pipeline. And one of the new group of drugs is the non-peptide oral GLP-1 receptor agonist. The beauty of these drugs is they're not associated with the hazards of oral semaglutide. And this new drug, orforglipron, has already been approved by US FDA in April 26, and in the DEN trial, it has shown reduction of 11.2% in a dose of 36 milligram, and you can see more than 15% reduction was seen in 36% of patients. We have quadruple agonists now, which are being evaluated: GLP-1, GIP, amylin, and calcitonin, and a combo of quadruple agonists. And now we have once monthly injections for obesity also. You can see this agent, Magarpatta, peptidoglycan, 140 milligram every 4 weeks. And this is another oral berobenatide, which is given at 1.6 milligram every month. And in the Vesper 3 trial, they show 12.3% reduction in weight. Usually, when we talk of any drug in clinical practice, the dicta is one size does not fit all. But GLP receptor agonist semaglutide is an exception. If you see, it has data in obesity, type 2 diabetes, ACVD, HF, CKD, dyslipidemia, inflammation, and even NASH. So GLP receptor agonist semaglutide is kicked off a new era of drug revolution in obesity. Semaglutide is also showing similar data, and some of the trials are ongoing, and when these trials are complete, I'm sure this will also go in similar direction. Insulin has been the savior for type 1 diabetes. Will new anti-obesity medication be the savior of cardiometabolic diseases, type 2 diabetes, and other? Possibly yes. Now, whenever we are using these new anti-obesity medications, one of the most important side effects is sarcopenia. We do not want our patient to develop sarcopenia. Sarcopenia should be preventive. It has occurred, it should be diagnosed at the earliest and should be addressed at that very moment. We don't want our patients to walk like this. Patients should have high protein intake, 1 to 1.5 gram per kilogram, and should have resistance training exercises. Don't forget, sarcopenia is an organ of longevity in patient taking anti-obesity medication. In an healthy patient, muscle is the ultimate anti-aging tool. The big question for the future is, can we have fat loss without muscle mass? And this is being addressed by a combo of semaglutide and bimagrumab with a monoclonal antibody builds up muscle, and we are keenly awaiting the results of the Dileep trial. Research in obesity continues unabated, and the future is very exciting. We have precision obesity care, which has come in vogue. We have AI-based tools to detect who is at the highest risk for diabetes, stroke, CKD, and so on. We have artificial intelligence in obesity care, and global recognition by WHO is one of the major advances in treatment of obesity. These are the 10 things you must not forget while using anti-obesity medications. Focus on fewer meals and not on no meals. Don't ignore protein. Don't go to zero carb. Don't forget to hydrate. Don't rely on medication alone. Don't eat heavy greasy meals. Don't stop staying. Don't obsess over the scale. Don't quit too early. Don't try to be trying to do it all the persons who are working in the obesity clinic. We have a panoply of new anti-obesity medications in the pipeline, as you can see on the screen. And this is the timeline for new anti-obesity medication 2026. Cagrilintide may file FDA approval. Then 2026, we have semaglutide and retatrutide, and so on 2028 and 2029 and 30. The next 5 to 10 years are very exciting in the treatment of obesity. Progress never stops, and innovation will continue in obesity. Thank you very much for your time today.
Thank you, sir. Thank you for your insightful knowledge on obesity and the future of obesity treatment. So this was all for our today's virtual session. I would request all the faculties and the delegates who have checked in Sheraton, kindly do join us for the dinner at Bonvoy restaurant in Sheraton Grand at around 7:30. We would love to have you there and for the lovely interaction. Also, tomorrow it would be a day where we will be sharing all our insights, and we'll learn more about on obesity and all the three halls of Sheraton Grand. All the three halls are power packed, and let's meet tomorrow on time at sharp 9 a.m. for the academic feast. Thank you, everyone. Anything you would like to say?
Thank you, all faculties, for sharing their insight about their particular expertise. We would like to thank all the delegates who have joined this meeting, and a special thanks to Rima Madam and organizing committee who are working relentlessly for this conference. We would like to see you on the dinner tonight, and tomorrow we will be meeting in the main day of the conference that will be conducted starting from 9 a.m. morning.
For today's virtual CME, I would special thanks to all our faculties, Dr. Rima Kashiva ma'am, Dr. Tomatoka, Khushbu Verma who has joined us from Glenmark, Dr. Anu Mahajan, Dr. Shejali Mehta, Dr. Tripti Dev, Dr. Satish, and Dr. Suhas Khere, Dr. PC Manoria, Dr. Manoj Dureraj sir, and Dr. Sujit Savarkar. Many, many thanks to you. Thank you.